So, great colleagues, good morning. Can you hear me? Good. I guess I will have second attempt. Dr. Gary Aslanyan had the one yesterday, but I'm encouraging you to sit as close as possible. And the reason of asking this is that the aim of our gathering is not just hearing new knowledge and sharing our research outcomes or stuff that we are making. It's about networking. And if we will manage to get closer to each other, I do believe that we will manage to do work in a close relationship with each other. Probably before I will start welcoming remark, I don't know, maybe it was to introduce myself. My name is Maya Uchanishvili, and I'm working for Curation International Foundation, which is a non-governmental organization working on health policy and systems research and health system strengthening in the region. From 1994, we are 30 years old this year, and happy to celebrate this very nice anniversary with you guys. Once again, yesterday we had a great welcoming remarks, but I have to use this opportunity and once again would like to welcome you and would like to say huge thanks to all of you to take your time to travel or to dedicate your 2 days to this conference. And I do believe that we, as a society, as a community, as a network, let's call it however we do prefer, will manage to collaborate in the future. Thanks to all organizers and funders who make it happen, especially to our hosts. Huge thanks for everything that you managed to do. And my role today will be you will see me here a couple of times. I would like to remind ourselves that yesterday we had a great session on health financing. And probably some of you are thinking why we decided to talk about the health financing. And the reason behind of this, it's not only that this is one of the great and interesting topic. The reason behind this is that in our region, and especially in a sub-region, which is so-called Eastern Europe and Central Asia, the most of countries are low middle income countries, and they are dealing with health financing from day to day over decades. And we as a society of people who are working on healthcare are trying to identify the most effective ways to finance our health needs and needs of our populations. And that's why we decided to have this session. And session was, from my point of view, very interesting, but I will not go into integrity of this because our scholars will do presentations during the day about each session. The second session was on primary health care, and this is one of the most popular topic in our communities of healthcare workers and health systems researchers, because there is so many things to investigate and to strengthen, and many countries are willing to strengthen their primary health cares and willing to make it better on an objective or aim levels. Unfortunately, not much are investing properly in primary health care, which has been discussed yesterday. So that's why we decided to have those sessions yesterday. Another angle which will be discussed today after my welcoming remarks on a health governance session is transparency, accountability, corruption, which is also the case in many of countries from which we are coming from. And that's why we decided to have and the session will be chaired today by Radmyla Hrevstsova. Thank you, Radmyla, for taking this very important role. And it was co-designed with Mark Hellowell, and both of them will be chairing, and with the distinguished panelists and presentations, they will provide us with information, what is happening in the region, what are the consequences of the corruption and of the not well developed institutions and non-transparent and not accountable institutions who are dealing with the health systems. And then we will have very interesting session with the participation of scholars. And I would like to use this opportunity now and would like to ask scholars. We have scholars in our conference. I don't know how much of you know this. Those were people who applied, who have been selected, who expressed their interest and motivation to become part of the society, to become like in the future for their career, well-established researchers in health systems and policy research area. So I just want you, scholars, ask you, just raise your hands or stand up. Let's see who are you. Please stand up and let's applause to them. They managed to get the scholarship thanks to WHO TDR. They are here, and to Alliance for Health Policy and Systems Research. And those scholars will be reporting back on what was the highlights from session 1 yesterday, session 2, and today's session on governance. So they will tell us what are the major issues on health financing, primary health care, and in the governance. And after this, me and Adriana will try to make participatory session with your engagement to identify what may be common issues we would like to research or work on or publish together, or what are those capacity gaps we can work together with the help of Health System Global or with the help of each other, because I do believe that there is much more possibilities in our region than we even just know. So let's try to use this final session to think about how we can collaborate or what are the possible linkages between us. And the very, very final session will be I will try to introduce you the new very emerging network and encourage you to be part of this. And once again, thank you for being here. Now I will give the floor to Radmyla and our first session on health governance. Thank you.
Good morning, dear ladies and gentlemen. Welcome to the third session devoted to health system governance. And today we will be talking about the principles of transparency, accountability, the principles of rule of law, how they are translated into real life experiences, and how they can help improving health outcomes, strengthening health systems, especially in the times of crisis, in the times of war and other health emergencies. My name is Radmyla Hrevstsova. I'm an associate professor of the Taras Shevchenko National University of Kyiv, and also affiliated with the Kyiv Medical University. I deal with health law and public administration, and also practice an attorney in the sphere of medical law and pharmaceuticals. And I'll be happy with the help of my esteemed colleague, Mark Hellowell, and our panelists and contributors to discuss those things with you. Please feel comfortable, feel free to raise your questions, to share your opinions, your reflections. So we will start. We have already started, actually. And do we have connection with our speakers who are online? Well, many of our speakers today will be online. Some of them will be offline, will be here in this room. So it is my pleasure to invite Dr. Ismail Anas. And also I would like to invite a few contributors, very good professionals. Dr. Jerzy Bednarski from Poland, please join us here. So could you please also, Nataliia, Katerina, could you, oh, I'm so sorry. Katerina, could you please also join us? And Tatiana, could you please also, Tatiana Yurochko, are you here with us? Could you please also join us? Of course, they are not all of the contributors. We will have much more contributors, and I hope that all of you will be our contributors today. So please take your seats. Okay. And now I have a great pleasure and honor to introduce our keynote speaker, who will give us an incentive for our today's work. It is my pleasure to give the floor to Professor Simon Wigley, the Dean of the Faculty of Humanities and Chair of the Department of Philosophy at the Bilkent University. And I hope that Professor Wigley will tell us how to translate democratic experiences into the realities of healthcare provision. So, Professor Wigley, the floor is yours.
Thank you very much. I'll share screen first of all, so hopefully this will be visible in a second. Okay, is this, everyone can see this? Everyone can hear me, I assume?
Yes, we can hear you well, and we see the PowerPoint presentation. Everything is perfect, thank you.
Thanks a lot, thank you. So I should say many thanks for the invitation to attend and participate in this wonderful event. Unfortunately, I broke my leg recently, which is why I can't be present, but also it explains why I'm sitting in such an awkward position. So apologies for that. So I'm really looking forward to the discussion this morning. But first of all, I will provide some of the results of studies that I've been working on with colleagues over the last 10 years or so about potential linkages between democratic institutions and population health outcomes. So my background is not in medicine. It's, as you can probably heard, it's in philosophy, but also in political science. But global health is something I've been working on a lot. So some of the methodologies I use may not be so familiar, but I'm happy to clarify those as we move along. So what I thought I would do is begin by explaining some of the background ideas and theory for the work that I do. And then to pick sort of four studies, four pieces of work that may be useful for the discussion that we might have today. So they're kind of not highlights, but specifically picked because they fit, hopefully, the discussion. So let me begin by just giving some background and some theoretical clarification. So, why does democracy matter? You may think that democracy sometimes doesn't seem to help very much. Life expectancy in the US has decreased recently, for example. Doesn't seem to be very productive at the moment. Of course, the debate is that some people argue that democracy in the US, at least in the near past, actually eroded. So there's a debate there, even in the case of what seems to be a well-established democracy. So there's kind of two broad claims, and I realize there's a lot of detail underlying these claims, but let me present the broad claims. So the first broad claim is that democratic leaders have an incentive to provide healthcare or any kind of welfare promoting resources to a wider share of the population, simply because they need to win the support of more of the population. They don't need the support of everyone, all voters, but they need more than autocratic leaders. That the comparison here is with autocratic leaders, where typically, with very rare exception, autocratic leaders can usually survive by securing the support of a narrow elite, whether it's business, military, and so forth. They only need to keep that smaller slice of the population satisfied to maintain their grip on power. So there's less incentive to provide healthcare to a wider set of the population, is the claim. And the second claim, general claim, is that autocracies tend to not, autocratic leaders tend to reduce communication openness. They want to reduce criticism, reduce the opportunity for protest, for citizens realizing that they can collaborate to protest the government. So usually there's a strong incentive to maintain control over the flow of information. This is, as has been noted by others, the kind of one of the main Achilles heels of autocratic rule. The autocratic leader may actually want to find out more about what is needed and where in terms of healthcare, but they lack enough reliable information about where the intervention is needed, and even if there is intervention, whether it's working. Whereas in a general sense, democratic leaders are going to get feedback from citizens through votes, civil society organizations, whether professional or non-professional, and an open media. So this kind of flaw of autocratic regimes has been noted by others, including autocratic rulers themselves. So just one example is that after the tragic famine in China in the late 1950s, even Chairman Mao realized that, because famines are preventable, they're entirely preventable outcomes in terms of crises. Even he bemoaned the fact that if I only knew more about what was happening at the grassroots level, we could have stopped this. So it is kind of really is a weak spot for autocratic regimes. I should, and people may want to ask about this later, I should sort of explain what I mean by democratic regimes. That's kind of the million-dollar question sometimes. So I have a very minimal conditions for this, the absolute minimum. So hopefully the least controversial definition of democratic governance. And the first one is obvious, that there should be the right to vote for all adults. The second one is sometimes underappreciated, but there should be multi-party elections that are competitive. Competitive means free and fair. There's a chance for the opposition to win, to put it simply. A lot of regimes since the 2000 mid-90s have shifted from classic autocratic governments like military regimes and so forth to having elections, but arranging or the setup such that it's very hard for the opposition to win. So it has the veneer of democracy, but in fact it's not, because the opposition, barring rare events, cannot win. And the third condition is communication openness. So this is freedom of expression to some degree at least, and media freedom. Hopefully these are kind of minimal conditions that are uncontroversial. So if we take this background and I now will look at some of the results of our studies. And the first one looks at cause-specific mortality. So it's not it's not a general indicators of population health, like child mortality or life expectancy. This is very coarse-grained kind of study of causes of death. And it's from a 2019 Lancet study that we published. And this is one of the results, and this may not be entirely clear on screen, so I will just zoom into the key highlights here. On the left, we have the breakdown of causes from at the top cardiovascular to at the bottom musculoskeletal. And we have a model predicting what predicts these causes, which includes GDP, development assistance for health, population urban, and of course, democracy. It also includes mortality shocks like war, famine, natural disaster. So the blue is the effect of democracy, the proportion explained of that cause explained by democracy. And for the sake of simplicity, the other one I'll focus on is green, light green, which is GDP per capita. And as you can see at the top of the bars at the top of the screen, democracy actually is more important seemingly than GDP. But as we move down, sometimes increasingly GDP becomes more important in terms of explaining that cause. So for cardiovascular diseases, which is, the burden of disease for cardiovascular globally is, as we know, is very high. Democracy actually explains more than GDP for this cause. And likewise for transport injuries, tuberculosis, and NCDs. So it's a somewhat surprising result, maybe. You'd think GDP would rule the outcome here, but seemingly not. However, as we move down the bars, increasingly infectious diseases, democracy is still relevant, but GDP becomes more relevant. So we're starting to pick out infectious diseases which may be more prevalent in lower and middle income countries. So you can kind of see the dynamic here, hopefully. So I'll just move to summarize those results. That democracy explains more of the variance than GDP for cardiovascular, transport, cancer, cirrhosis, and other NCDs. And just to emphasize why that's important, in 2016, of course, increasingly so, those four causes accounted for a quarter of the total death and disability in individuals younger than 70 in lower middle income countries. So this is a big slice of the health burden in lower and middle income countries. That is where democracy seems to be quite important. Not the only factor, of course, but it seems to be important. So I'll now move to another study which we published in the BMJ, where we look at not democracy level so much as decline or erosion in democracy. Since there is kind of accepted now that since the late 90s, especially 2000s, a number of countries actually that were at least democratic in some respect actually declined in terms of their level of democracy. This is called autocratization, just the opposite of democratization. So we look at these episodes of autocratization and its effect on universal health care coverage in those countries. And the method we use here is to kind of compare what actually happened on average for those autocratizing countries. So we treat autocratization as kind of a treatment. And what would have happened if they had not autocratized. So the method here, I won't go into the details right now, but the idea is that in the top screen, the dark purple solid line is what actually happened for universal health care coverage. And the yellow dotted line is what we predict would have happened without those autocratization episodes in those countries on average. And the lower figure, the bottom of the page, is just summarizing that result. All it is, the difference between the what happened and what would have happened is that graph just shows the difference. Only the advantages that includes confidence intervals in the lower part of the screen. So that seems to indicate two things so far. That one is democracy seems to be important for health in general, all causes in general, but especially perhaps NCDs. And autocratization episodes, which has been prevalent over the last 20 years or so in some countries, seems to be significant for the provisioning of healthcare. So we now shift back to level of democracy rather than decline in democracy, and whether it affects by itself universal healthcare coverage. So the outcome variable, so to speak, is the same here. The difference is we look at recessions. What happens when a recession happens? How do democracies react to this in terms of healthcare coverage, and how do autocracies react to this in terms of that coverage? And the method is the same, so it'll save me having to re-explain some of this. This is just the difference between the expected and what actually happened in autocracies. The lower part of the screen, the horizontal axis, is just time to recession and after recession. So before recession, the model is predicting that, it's predicting what actually happened, because we know what happened. After the recession, autocracies, it seems, reduced universal healthcare coverage. So after year zero, there was a decline in healthcare coverage when there was a recession. But if we compare this with democracies, we have the opposite effect. When there's a recession in a democracy, it seems that there's an increase in universal healthcare coverage in response to economic recessions. So the sort of final set of results I would like to present, which is work in progress, and I think it may be of interest for everyone, because here we shift from national level estimates of, say, cardiovascular, universal healthcare coverage, and so forth, to within country distribution of healthcare outcomes. As we know, this is crucial. I mean, a country could be doing quite well on one of these indicators, say, life expectancy, under 5 mortality, healthcare coverage, but there could be some regions in that country that are doing very badly. Or the reason for the low national average, it could be because of this dramatic variation within country in terms of healthcare delivery. Some regions some locations may be doing extremely well in terms of healthcare provisioning. Some may be doing extremely poorly. So in this study, we're looking at under 5 mortality because the data is only available so far for that outcome for lower and middle income countries, 87 lower and middle income countries for the years 2000, 2017. And we're looking at the spread or variation in under 5 mortality within each country. How spread out is it? And we use something similar to a Gini coefficient for this. So it's like how much inequality across regions within each country is the outcome variable here. And on the screen, you can see on the left is obviously autocracies, and on the right, democracies. And we can see that inequality in under 5 mortality is higher in autocracies than in democracies. This is based on predictions controlling for GDP and so forth. So you may think, well, okay, inequality by itself is not bad. We're really worried about outcomes in terms of the worst off in each country. That's what we're really interested in. You know, does the inequality implicitly capture the effect that whether this is advantageous for the worst regions in terms of under 5 mortality? So the next figure, and this is my last figure, is looking at the 90th percentile, the kind of the regions in each country where under 5 mortality is the highest, and predicting what the level of under 5 mortality would be in those locations, subnational locations, depending on regime type. So again, we see that autocracy under 5 mortality is higher in those worst performing or high mortality locations compared with democracy. So it looks as if the inequality, the greater inequality or that we observed in the first figure in autocracies is primarily because autocracies are not very good at looking after the worst performing or the high mortality locations within its country. So I'll just quickly summarize these results because I realize we're running out of time. So first of all, especially for NCDs, the democracy is more important than national income. Why is that important? NCDs are globally increasingly, in most countries, are the biggest burden in terms of death and disability, and increasingly in lower middle income countries. And some may say that this is like a slow burning crisis because the rate at which there's a transition from communicable diseases to non-communicable diseases in lower middle income countries is happening at a far faster pace than it did in today's high income countries. So it's happening quicker. Plus those countries are quite often not prepared for this. In terms of democratic erosion or autocratization, we find that it significant declines in the level of democracy is associated with lower universal health coverage. And thirdly, autocracies increase coverage in recessions, decrease coverage in recessions, democracies increase in these recessions, which by the way, these are significant recessions, not just small recessions. Most of them around 2008, which is probably no surprise. And finally, in lower middle income countries, democracy is associated with lower under 5 mortality in those within country locations with the highest mortality rates. And before I conclude, I just should thank my co-authors that I work with quite a lot for these studies, which is Tom Boyke, Tara Templin, and Joe Dielman. And thanks for listening. Thank you.
Thank you very much, Professor Wigley, for such a brilliant presentation. Actually, I believe I will express the general opinion that we are very much impressed with the results of Professor Wigley research. And such results are worth sharing among decision makers throughout the whole region. For example, I believe Ukrainian decision makers will be very interested in learning the results of his research. And this is a very good incentive for us to think of it and maybe to start researching the situation with it in our countries. And Professor Wigley, are you with us?
Yeah, yes, I can hear you, yes.
Excellent, thank you very much, because brilliant presentations always give rise to many questions. And I'm sure that there are many questions here in this room and probably online. So if our participants online want to ask a question, please raise your hand and you will be unmuted. If you want to ask a question, please raise your hand likewise. At the same time, I know that it's sometimes difficult to be the first who asks the question. So who is brave enough to ask the second question? Yes, please. Could you please introduce yourself and ask a question? Well, do we have a micro? Yeah. Mm-hmm.
My name is Sarah Czausiewicz. I come from the Stockholm University. I'm a postdoctoral fellow in public health sciences. I read a lot, but I would like to hear from an expert. How do you comment on different news and different research that speak that autocratic regimes fared better off during COVID-19 when it comes to lockdowns and et cetera, So since you seem to be an expert in this field, I would just like to hear your opinion and your thoughts on this.
Yeah, that's a difficult one. As we know, no countries seem to do very well during COVID. There was flaws everywhere. So it's a matter of how badly countries did. I think there was a lot of studies done on regime political institutions during the pandemic itself, before we had reliable excess mortality data, and not just reliable excess mortality data, but also data that accounted for age. So the biggest cause of death is actually age. So those countries with a higher median age, there was more mortality. So it was harder for those governments to tackle the problem. So I mean, this is kind of avoiding the question a little bit, because actually the first answer is, it looks as if democracy did not help during the pandemic or democratic institutions. However, we only now have data that is reliable excess mortality and adjusted for age. So only now, I think, can we actually look at that question properly, because those countries that seem to have a huge mortality during the pandemic are also those that had an older population. So that's kind of a question, unresolved question, actually. Studies that looked at previous crises like SARS and so forth, it's inconclusive because it was all in one region. So it's a very tricky question, but vital, it seems. So I'm the results so far suggest that democracy didn't help, but I'm interested to see what will happen when we look at excess mortality with age adjustment. Thanks for the question, by the way.
Thank you very much, Professor Wigley. Thank you for a brilliant questionnaire and a brilliant answer. Any other questions from the audience, please? So can we move forward? I once again want to thank Professor Wigley for his research and for sharing the results of his research with us. Thank you very much. And now we are moving forward. And now I have a pleasure to introduce our speakers, our panelists. Each panelist has not more than 15 minutes for presentations. I believe it will be enough. I'm sure that every panelist can speak hours on his or her topic, but let's try to stick the time limits so that to leave enough time for a productive discussion. So now it is a great pleasure for me to introduce to you the person you already know, especially those who attended yesterday's part of the conference, Dr. Mark Hellowell, Associate Professor of Health Economics and Policy from the University of Edinburgh. And Dr. Hellowell is a person who extensively and intensively works for the WHO and other organizations in many countries, including in Ukraine. And here on the surface, Dr. Hellowell knows much, helps much. So Mark, the floor is yours.
Yeah, thanks, Radmyla, and Good morning, everyone. I don't have a presentation as such. I'm just going to say a few words to sort of set out the basic conceptual framework and the purpose for this session, and very much inspired by what Simon has just been saying, and with knowledge of his work, which has been a source of inspiration to me and for this particular panel. So look, yesterday we were talking in the morning about health financing, and in the afternoon about service delivery arrangements in healthcare systems and the importance of primary healthcare and these sorts of things. Topics which are, at least superficially, very sort of technocratic issues, technical challenges that require technical solutions. And insofar as that's true, then you could say that, you know, the role of the research community is to provide the evidence base on which those technical solutions should be based. But in the Q&A, we started to see other important concepts sort of entering naturally into the discussion. So a few people asked questions around trust, around social institutions, and yeah, the importance of sort of intangible but nonetheless critical concepts like accountability and transparency. And so that's what we're trying to talk about and focus on in this particular session. And I think, as Simon and his work have alluded to, accountability and transparency are things which are promoted by, enabled by, and maybe are prerequisites for strong institutions, and often embedded within open, inclusive political institutions, those, for instance, that we associate with liberal democracies. And it could be hypothesized that in the context of these sort of strong, inclusive political institutions, and maybe only in that case, can you really make serious efforts to address some of the challenges that we're all concerned about. So, you know, in relation to health financing and primary healthcare, for instance, where Ukraine has made really significant progress over the last decade, you know, as I mentioned yesterday in my brief presentation in the morning, it was really after the Revolution of Dignity that the political arrangements were such that you could actually make serious effort to move ahead with health financing reforms and health system reforms underpinned by the principles of universal health coverage. To really, you know, there has been this long-standing constitutional commitment to equitable access to healthcare with financial protection in Ukraine, but it was only really through these reforms, which came about in the aftermath of the Revolution of Dignity and the changed political circumstances that brought about, that serious efforts to realize that constitutional commitment have been made. And I think it's also in the context of institutions that promote accountability and transparency that we can effectively address a broad range of other challenges. So in this panel, we're going to be looking at challenges such as informal payments, corruption more generally, other ethical challenges, such as those which may arise within the healthcare professions, how implementation of policies and interventions can be made more effective by, you know, effective engagement of other social stakeholders, the professions, and also communities. So that's really the sort of red thread, I guess, that connects the various pieces of the forthcoming panel. Thinking about these challenges and how they can be addressed through stronger institutions, through institutions which promote accountability and transparency, and what that really means in practice. So, you know, one of the key geographical foci of our conference as a whole is on Ukraine. And many people in the room and many people online are Ukrainian. And I don't believe that our Ukrainian colleagues will require much persuading that, you know, democratic institutions, accountability and transparency are really fundamental in terms of addressing and responding to big societal problems. I guess we all need to recognize that collectively as a group of scholars. We're not just dealing with technical challenges, although we are doing that, and that's hard enough. We're not just providing evidence for technical interventions. We also need to be knowledgeable and, aware of the fact that our ability to address those challenges is shaped by the constraints and opportunities created by broader political and institutional contexts, and perhaps in some cases even be part of the process of change. So with that, I will hand over to Elina.
Thank you very much, Mark. Before Elina starts speaking, I would like to tell that Mark was one of the persons due to whom our yesterday's and today's gathering happened. And thank you very much, Mark, for pointing out that today we are discussing concepts, because it is not possible to resolve technical issues without understanding concepts and what meaning is conveyed by those concepts. It is our pleasure to give the floor to the next speaker, which Mark has already advertised. And yesterday, those who attended the conference yesterday already had a chance to listen to the presentation of Elina. And today, Elina will speak again, and we are very happy with that. So the floor is given to Elina Dale from the Norwegian Institute of Public Health. And Elina is a senior advisor at this institute, having more than 20 years experience of working on health, finance and policies and other issues which are extremely relevant to our today's discussion. So, dear Elina, the floor is yours.
Thank you. Can everybody hear me and see my slides? Great, I see Simon nodding. So yes, just as a preamble, why Norwegian Institute of Public Health on Earth is working on this. So this is today, I will present a lot of the work that we did as a result of the interest that Norwegian government, Norwegian Development Agency had in this topic, and they commissioned work to us because we are the knowledge arm of the Norwegian government when it comes to health. And together with the Bergen Center for Ethics and Priority Setting and the World Bank Global Practice Team that was led at that time by Krzysztof Kurowski. So, and we also engaged a large group of experts, including from LSE, and I see that, Simon comes from LSE background. So we worked closely with the philosophers from LSE and other universities, and also policymakers from a number of countries. So what I'm presenting is really a joint work. So this is the outline of my presentation. And basically, I'd like to give a bit of motivation of why, and I think already Simon gave enough motivation for us to care about this topic, but I will also go with more specifics on health financing, and then on why we felt like we needed to develop this framework on what we call fair process, and present that framework briefly, and then examine this in the case of health reforms in Ukraine, and then we'll have a little discussion, hopefully. Now, it is impossible for those of us who are dealing with universal health coverage and health financing to avoid this cube. But basically, it's when we often talk about the UHC, we talk about, we are used to talking a lot about substantive fairness, right? How to fill in this cube, what are the trade-offs? Do we increase the breadth of coverage, but maybe have only certain population groups covered? Or do we reduce user fees and have a broader coverage of the population? So these are the 3 dimensions of the cube, and hopefully it's quite familiar to everybody. But this is the issues of substantive fairness. And a lot has been written on that, including by WHO and some of the key experts from Norwegian Institute of Public Health and the Bergen University that deal a lot with this kind of priority setting. Then there is an issue of procedural fairness. It's more how to fill this cube in a way that would be really perceived as fair, that will consider different views in the society that people have, and that would really promote trust and durability of the reforms. Because while in health financing, and I come from that background, we often think, as Mark said, that there are technocratic solutions, right? And that we, the economists, might know best how to fill in this cube. But there are still lots of issues around it, and even around the seemingly technocratic decisions. And there is more and more literature that shows that actually how you make the decision matters just as much as what decisions you make. So those who have kind of looked into these issues of procedural fairness and how to make decisions in health are probably familiar with the work of Norman Daniels on setting limits fairly, learning to share resources for health. And that's really seminal work on this. And he and Jim Sabin, they proposed this framework that had 4 conditions. And they talked about the fact that the decision, when the decisions are taken, first of all, they have to be there has to be publicity around them. So, you know, they have to be shared with those who are affected by these decisions. There should be revisions, opportunity to have revisions and appeal those decisions. And there should be enforcement of these 3 conditions above. And this, a lot has been published using this framework and looking at the decisions both in US, Mexico, but also low and middle income countries. And but there has been some critique of Norman Daniels's work, particularly this the fact that the framework has been applied and developed really for the decisions around the benefit package. And but in health financing, there are also decisions that are about revenue raising, right? How do we, and we talked about it yesterday, what are the sources of financing, for example? What is the role of out-of-pocket payments? Then there's pooling. And so there was a feeling, at least among those who work on health financing, that this framework didn't apply so much or so easily, perhaps, to those decisions. Then the interpretation of the concept of relevance and how it became applied, it in a lot of literature, it became reduced to cost-effectiveness analysis. And that's one of the considerations, of course, that could be, but many criticize that, you know, there are other considerations, for example, that could take place in, for example, in Nordic countries, solidarity could be the most important consideration. Then there was not enough emphasis on public involvement. And while publicity implies some public involvement, and a lot of the times it was also when the studies have been done, they did look at stakeholder participation, but it wasn't the necessary condition in the A4R framework. So building on Norman Daniels's work, but also going a little bit beyond that and looking at the literature from taxation literature, public financial management, environmental literature, and other, we came up with this framework where we said the core principles of good decisions or fair decisions are equality. And here it's not equality in the outcome, right? It's equality of the process. For example, if we're having a meeting, do I have the same opportunity to speak? Even do I have the same capacity to express myself? Simon might be much more articulate than me, so it might be that suddenly I'm put in a less equal position. So these are the kind of equality that we're looking at. Impartiality, I think that's quite clear, it's to ensure there is no conflict of interest, although some scholars increasingly say you can't be completely impartial. All of us have some interest in decisions, but at least unconstrained or kind of self-interest is bad. And then consistency over time, and it's should be intuitive, but the rules of the game, you don't change them when you start the game. So it's good, that there should be a process also on changing the rules of the game, and they shouldn't be changing all the time, making things unpredictable. And around it, there are these criteria that are organized by the domains: information, which is reason giving, and that was really also in Norman Daniels's framework. It's that whenever you make decisions, you have to justify them. And that's also the core of deliberative democracy, that whenever you can't just make decisions, and because we should respect each other as human beings, as governments towards citizens, citizens towards governments. It's at the core of this mutual respect. And if you respect somebody, you should be bothered basically on providing reasons, and genuine reasons on why you think what you think or why you made a certain decision. Transparency of the process and of the actual decisions, and accuracy of information. Then we have voice, which is about inclusiveness and participation. So inclusiveness is not just about counting. So participation is, direct participation, but inclusiveness is not so much about, counting heads, but it's more about the how many different voices, how many different opinions are included in the dialogue. So that could be through this, what Simon said about the openness and communication through media, what kind of different opinions can be expressed on a topic. And oversight, which is basically that all decisions should be revisable if new evidence arises or new good reasons are developed. And then enforcement of the process, and also to some degree decision itself, because as one of the key scholars in deliberative democracy said, that it's, we're not engaging in academic debate, so it has to be that whenever we engage in these discussions, we should believe that we do have some influence on the final decision. So with this, now I will switch so I'll just quickly say, so why we believe that a fair process was important. And that's, first of all, and some of it is empirically provable maybe, and some of it is not, and it's more, let's say, my colleagues who were in this group writing this report, developing this report, also came with more philosophical arguments why this will be the case. So first of all, we believe that this kind of process that I've just described improves policies. So why we think so? First of all, we think whenever you have openness and you have to justify your decisions and you provide reasons and do it so in public, the bad ideas will be exposed somehow. And it's also that there will be less room for misunderstanding or wrong expectations, right? Because you're kind of clear about what is it that you're expecting, let's say, from this health financing reform. Do we expect improvement in financial protection? Do we expect it in the short term or long term? So, and also there is more literature also showing that, demonstrating that actually citizens, when they come together and they're provided good information, they can come up with pretty good decisions together. Now, we also believe that this kind of fair process will reduce corruption and increase equity. I think there is plenty of literature that transparency can lower fraud. But we also think that, you know, when you have inclusiveness and participation, especially in countries where, what Simon, you know, where there is no well-established democracy, it can be that those who are supposed to represent the population, let's say members of the parliament, might not be actually representing the population so much. And it could be that a more direct participation will increase the equitable decisions and the likelihood of taking equitable decisions, and reduce this opportunity for corruption. And there is some evidence. There was a recent review by the Open Government Partnerships done, which provided evidence that by improving oversight by auditors and civil society in Ukraine in 2015 through more open system for medical procurement, that there were substantial savings and reduced corruption. So that's a very interesting case. Of course, it's just a case study, so but it's worth looking at. Then we also have plenty of social psychology literature that shows that when you listen to a person, to your opponent, even if they eventually disagree with the kind of decision that you take, they are more likely to trust that decision and accept it, even if they may disagree with the actual decision. And there's also literature in voluntary compliance with taxation that shows this. And then improve sustainability. We, as a result of the above, we also think that, and there is some maybe not, you know, very strong quantitative or randomized control trial type of evidence, but there is some evidence that there can be less opposition to the decisions when you go through this type of fair process. Now, while I will talk about Ukraine today, it is very important, and I think that was one of the key messages of our report, is that this doesn't only apply to Ukraine, or it's basically the issues that we're raising, they apply to well-established democracies, because there's always room for improvement, as well as, let's say, younger, evolving kind of democracies. And this is an example of Norway, where we had government commission set up to look at the openness and participation. in health care decision making and priority setting. And there was quite a thick report coming up with ways we could improve this. And this is not the first time we're looking at this, but basically it shows that there are also issues in countries such as Norway where the way we make decisions could be improved to increase trust of the population and to really make sure that citizens' voices are heard. Now, this timeline of Ukrainian reforms have been seen a lot since yesterday, but I'm just showing it again because it will be important later when I talk about why some of the things that we say should be done are actually difficult to do in real life, even if we should all try to do it. And that's one of them is the political windows of opportunity. And I think those who, and many of you who know this, the timeline of the way the reforms have started in Ukraine can understand why this issue of we have little time, we have to move fast, was one of the issues in the way the reforms were implemented. So now it's always difficult to speak to an audience about their own country and not being from that country, but let's say in my defense, the work on which I will be drawing was done very closely, and actually the paper was led by Yuri Drigir and with Katya, whom probably many of you know, so two Ukrainian authors, and also I have worked and been kind of part of some of these reform decisions. So some of the issues that people didn't necessarily agree with, as I said earlier, that they can be technocratic decisions, or we think we know what's best, but some people may disagree, and quite justifiably so. So these are the points of disagreement. So I'll try to hurry up. And just to say that sometimes when I talk about this work at least in Norway or somewhere, people become a bit skeptical, saying, oh, but why should we care about don't you think during the war is like people have other concerns? We shouldn't be thinking about these reforms and how they were done, but just this to show that actually healthcare reform is still very high on the agenda in Ukraine. So this is the work, the paper that I said I will be drawing on when it comes to the case study on Ukraine. And just to say that I think it's also, this work complements somewhat to what Simon presented, both in methods and hopefully in content, because we looked more and we took a more case study approach, and one of the case studies was Ukraine. And while I will kind of use the findings from the reforms that we looked at that were conducted in the past, my main intention is to try to see what we can learn for the future. So, first of all, it seems that based on the key informant interviews that have been conducted by Katya and Yuri, in the previous phase, citizens were viewed more as listeners and not as active participants. So there was more of this kind of, and it's not only in Ukraine, right? That I think also took place maybe in Turkey or other countries when this kind of big reforms are being conducted, where it's more about marketing almost the reforms, right? And so the citizens, they, often we even call it information campaign. As if we're giving the information, but we're not taking back the information or their views. So that was one of the issues in I think the approach that the reform team took in 2016, 2020. And but what in deliberative democracy people argue is that there has to be a two-way communication. It's not just us, the experts, communicating to the citizens who are waiting to be enlightened. It's the citizens also have a lot to give to us. And so there should be two-way communication. And then in a country such as Ukraine, where people are defending this country literally with their lives, they have all the right in the world to be part of the decisions. So as the program of medical guarantees and the service packages are being developed and revised, and maybe the payment methods are being changed, or it is important to see if and how there can be mechanisms developed to include better civil society organizations and even lay citizens not organized necessarily in certain groups in this decision-making process. Now, another thing, I talked earlier about the inclusiveness, and it seems that one of the weaknesses also before was that certain types of evidence was not taken into account, that perhaps certain views were considered to be outdated, and they might have been. Health financing is a fast-moving field in many cases, but the point is that it is important to take into account various views and then to debate them through, and then maybe final decision will not be based on those views, but still the evidence cannot be just disregarded because we think the people don't have up-to-date knowledge or something. And that also goes to a bit to the objectives of this pre-conference and HSG, is that on the one hand, we have to take into account, of course, everybody's views, and especially local researchers, not just be driven with, oh, this is what WHO, the World Bank, or global literature says. But that also implies that the local research capacity has to be strengthened and become more kind of trustworthy when it comes to this kind of fast-moving field. I think the other point is that we have to be open about trade-offs and dilemmas, and it goes back to the deliberative democracy principle that we have to respect, and we have to treat humans as rational beings. And so if we treat each other and perceive each other as rational, reasonable beings, then we also give each other respect and can be open about the different dilemmas. So when it comes to out-of-pocket payments, one of the key kind of issues in Ukraine is, of course, very high out-of-pocket payments, including informal payments. And we talked about it a bit yesterday. But the point is that when the reforms have been launched, perhaps there was not enough communication about the fact that the reforms, no country can even eliminate or even decrease out-of-pocket payments overnight. And it's a long-term project, and it requires a lot of trade-offs that cube the substantive fairness issue. And so being a bit more open about it and clear might actually help at the end. And that's also the philosophy that Norway had during COVID, and Simon might come in and agree or disagree with whether it was good or bad, or how well we performed. But at least we believe that our openness about the fact that we were not sure about the evidence and how inconclusive the evidence was actually built the increased trust in the decisions that we've made during COVID. And then, of course, there should be a process for revising decisions and considering new evidence. And as the program of medical guarantees evolves, it's important that new services are being added, new reimbursement rates are developed, that they are not seen as ad hoc, but there is room for revising them based on good evidence and discussions. All this is not easy. It requires time, but going back to the timeline of the window of opportunity, they can be short. And so how to do that is, we haven't resolved that question. Resources, but conducting really good citizen engagement mechanisms, that requires resources, time and money, and it's not necessarily always there. And then it requires capacity of the government, local researchers and civil society to really value procedural fairness, to generate and use evidence in decision-making, and to engage effectively with each other and larger citizenry. But again, this is something that is not grown overnight, and we have to do it step by step. So some difficult questions that remain that we haven't solved, and actually there will be also a series of articles in the Journal of Economics and Law, if I can remember correctly, with some critique, and where we'll also try to provide response. So to what extent can shortcomings in process be accepted if the reforms can contribute to fairer outcomes? So that was kind of maybe the view of the reform team. There was no doubt that the health system financing in Ukraine had to change, and that eventually it will lead to hopefully better coverage, better outcomes. Can we accept shortcomings in the process? And then in highly polarized societies, where some actors are perceived as bad actors, basically, if we don't trust them, if we don't trust their motivation, if we think they are just protecting their own corrupt interests, should we include them in deliberations, and how? And then also very practical questions that we also struggled with in the recent discussions of the WHO resolution on social participation. If information and oversight are met, in what instances can we not include voice? Is that so important? A lot of the decisions in health financing are very technical in a way. Is providing having transparency and reason giving enough then in those cases? And very practical that we've actually came upon, and I think it's also a bit what Radmyla you're working on, is when it comes to voice, whom and how to include in deliberations. And one of the issues in Ukraine was the professional associations, how they're organized, who they represent. So if we don't have it like in Norway, we have many trade unions, we have different associations, we have very vibrant and diverse civil society that is organized. So then how do you include them? And what is the cost of good participatory methods, and who should be financing it? With this, I stop.
Thank you very much, Elina, for an amazing presentation. You've raised so many important topics, starting from the topic of trust, which for Ukraine is especially topical topic, sorry for saying like that, because, for example, in Ukraine, people more believe in medical professionals than in healthcare system, than more tried healthcare workers than healthcare system. So what should be done in order to increase trust to healthcare system to which healthcare professionals are a part of? the principles. You outlined a number of principles, and you know here there are a number of young researchers. Young researchers sometimes pay less attention to principles than it should be paid. But when assessing healthcare decisions, you may use those principles as a tool. And actually, each of the principles is a separate, deserves a separate study, a separate research. So I'm sure that you will continue with that. Thank you very much, Elina, for a perfect presentation. One question to Elina now, only one question. Next questions will be discussed during the panel. Who is willing to raise, to ask Elina a question? Please. Yeah, could you please introduce yourself and ask your question?
Добрий день. В мене буде запитання на українській мові. Мене звати Ольга Коваленко, я представник Київського медичного університету. В мене питання до пані Еліни. Ви дійсно підняли цікаву тему на рахунок принципів в охороні здоров'я. Мені б хотілося почути саме вашу думку про дієві механізми впровадження цих принципів, таких як якість, прозорість, інклюзивний підхід, ну ось саме на різних рівнях організації охорони здоров'я. Дякую.
Hello, I will translate. I will try to translate. Please keep me in touch if I will. So the question is about
about the principle.
what are the due to your personal point of view, what are the main principles in developed countries of like if you talk about more clarity, if you talk about financiation, if you talk about inclusive way of realization and changes and reforms to make healthcare better?
Thank you very much. I will add a little bit the mechanisms, what was asked, the mechanisms of utilization, of implementation of those principles in real life. What are those mechanisms at different layers, different layers? Thank you. What are the mechanisms of implementation of those principles at different layers?
No sound.
Can we hear you?
Okay, yes. Now I was allowed to unmute. Sorry, I was trying to use a sign language of my own. Yes, thank you. This is a very important question. I think that's so. What we do, for example, in Norway, one of the things is, and I think it's also in UK. When it comes to UK NICE, they include, for example, what they call lay citizen in the decision making when it comes to health technology assessments, right? That's one of to include in when you're setting priorities and discussing your treatment. Try to include a representative of the lay citizens. There are also for example, we also have this town hall meeting when it comes to the very basic municipal level decision. And just to say that primary care in Norway, it's at the municipal level, right? So that's and I think so. There are those mechanisms, and then but I think also what Simon was referring to earlier. In Norway, we have. I guess mass media communication that where it is very, you know, you have very different opinions, and every time there is some reform being discussed, let's say, whether there could be voluntary health insurance in addition to what we have this, then there are lots of voices. There is a debate in the TV program where these issues are discussed.
Thank you very much.
And then lastly is when our government was developing a white paper on priority setting, on the criteria for priority in health, then they actually actively involved citizens in things like citizen juries. And we can talk a bit more about later when, if we have time, about nitty-gritty of citizen assemblies and citizen juries being effective, but they can also be not so easy or expensive to organize.
Thank you very much, Elina, for
Thank you.
For a very deep answer to a very interesting question. I hope we'll be able to continue the discussion during the discussion session. And now I have a pleasure to give the floor to Nataliia Kovalenko, another speaker of our session, USAID Health Reform Support Project from Ukraine. Nataliia is an expert in healthcare financing. Actually, she's a health financing component lead at USAID, and she's also a Deloitte consultant. So I'm sure that there will be much interesting things to share, and we are eager to listen them from Nataliia. Nataliia, are you with us?
Yes, thank you so much. I hope you can hear and see my presentation, right?
Yes, so we see your presentation, and now we see you, and now we can see you. Excellent, thank you.
Okay, these fantastic Zoom technologies. So good morning. First of all, greetings from Ukraine, as I am now in Ukraine, in this very brave European country who are fighting for our freedom in 21st century. So first of all, my big thank you for inviting me to participate in this very great event. I can only imagine how it's beautiful to be in person for such an event and to have an opportunity to discuss with colleagues many of very interesting things that we can bring to our countries and probably improve some of the health systems. And thank you for the opportunity to speak about some of our studies that we have been conducting basically for the past 6 years. And we have now a right to compare a lot of things, a lot of changes in the health reform and the health system of Ukraine. As been already said, I'm representing USAID-funded project Health Reform Support, which is implemented by Deloitte. I'm leading the health financing stream in this project, and we basically are working since 2018. And basically, my first slide is to maybe show a little bit our project. And this is actually one of very interesting things because we have been talking, I think, the second day about how the system, the fair and transparent system should look like. And if you look at the structure of our project, you would see we are calling these like building blocks of the reform itself. And our work is actually built around these directions: governance, finance, health workforce, service delivery, electronic system. So everything which is needed not only to launch the system, but to effectively implement. We are trying to provide technical expertise around all of these 5 building blocks. And we are working in Ukraine since 2018. I think yesterday's presentation gave a lot of background how the reform started, what were the first steps in the reform dimension. And actually in 2018, our project started. So we were from the very first days of the reform implementation, and some of our studies basically were to answer some of the questions. And of course, fighting corruption was one of the key, because actually one of the reasons why reform has been implemented in Ukraine, because of the very high out-of-pocket, including informal payments, which were made by the patients, and that creates a really significant financial burden for the citizens. to access even the essential, like primary healthcare services in our country. So that was a very, very strong reason for making the reform, I would say, happen. We talked yesterday a lot about the pathway of the reform. I would not repeat all of that because everyone is familiar with that. So, but I would like on this slide probably maybe talk more about the healthcare providers, because we established the national purchaser. We have designed and implemented a very big state-funded program of medical guarantees. This year is something around $4 billion for the whole year, with actually more than 44 packages of medical services procured by the National Health Service of Ukraine. We have a lot of around this process. But also what is important to mention, and probably which we did not discuss yesterday, is that healthcare providers receive the autonomy to make a lot of decisions at their level. And that has actually a very clear pathway to anti-corruption measures, because once the healthcare provider is more autonomous, for example, to decide what the structure in terms of staff they would like to have, what type of salary payment system they would like to introduce at the healthcare provider level. If they have this autonomy, if they have no limitations set by someone like the government, they have an opportunity to design and implement more fair, more transparent, for example, salary system. And as you will see on the next slides on some of our studies, like question and issue of salaries is a very significant in the system, especially for low and middle income countries. If you're not fairly compensate the work of health workers, you cannot account actually for seeing informal payments of out-of-pocket payments close to zero. They will be always remain high because you don't have these opportunities around the system. So with being everything this in place, so we received the request from the government of Ukraine, namely from the Ministry of Health and National Health Service of Ukraine, to help them to understand, first of all, what is the level of informal payments for the certain services in the health system. And as the reform basically started from the primary healthcare level back in 2018, we started our research from the primary healthcare level to support the first iteration of calculating capitation rate, which is the dominating financial mechanism for the primary healthcare package in the program of medical guarantees. And then we, of course, moved to some of the services at the level of specialized or hospital level to explore a little bit more. Our ultimate goal was not only to measure the current situation, but also to highlight some of the reasons, like why this is happening, and to support some of fair tariff setting at the level of the national stakeholders, as well as try to help justify some of the high-level national decisions, for example, to design communication campaigns for the patients. Maybe they lack some of information not to pay for the services which are already funded by the government, and so on and so on. So these rich data, and I think we also talked yesterday that the data is one of the key elements for making effective evidence-based decision. And if you can rely on certain data, you can make these kind of decisions. So I already talked a little bit like why we conducted these studies and actually why the reform has been happening. Unfortunately, Ukraine is been associated with as a country with a very high level of corruption, and we saw this in many studies. For example, like corruption perception index. It's not specific for health, but it's about the whole system of Ukraine. And if you have corruption everywhere, of course, it affects health area as well. So unfortunately, we're occupying every year like a very high place. You saw the second graph yesterday, I think, in Elena's presentation. We have high out-of-pocket expenditures as well. And we also know that some of the services are critical for the patient. So it's very critical to measure these informal payments and understand what we can do with that and what probably can do in a short term and also in a long run as well. So first question that was come to our mind once we received the request from the national stakeholders is, of course, the definition, just because we have somehow to identify what is informal payments, because there is a well-known definition of out-of-pocket payments. But here we are focusing on informal payments because we have to understand what we can change in the tariff setting in the program of medical guarantees. So we have to understand informal payments which are made by the patients. And here we are identifying informal payments from very different perspectives. We are looking on monetary and non-monetary form of informal payments. So when we were asking patients like, did you make any kind of informal payments? We were always specifying. So it's not only about money itself, it could be like a gift or a certificate or whatever it is, which is also informal payment. And if, for example, some patients have this perspective, okay, but I made like an official payment and like the nurse made a note like somewhere. And when we ask, was it like an official document? Did you receive a recipe after this payment? The answer was no. So that was not formal official payment. This was one of the forms of informal payment, which are not accounted in the overall official incomes of the healthcare facilities, and that cannot be used, for example, for buying equipment or medicines or something like that. This is informal payment. And so many other examples also. Also, we asked like patients, and we counted these in informal payments, like for what exactly was informal payment done, for buying medicines, medical products, for just like gratitude to the doctor or the nurse for providing like essential services or maybe additional services. So we asked all of these very specific questions to understand what exactly informal payments are. And as I said before, so the first study that we conducted was for primary healthcare level, just because the reform started at the level of the primary healthcare level. So by the end of the day, we conducted two waves of studies, two studies. One was before the reform being implemented. So we measured the status quo, like what has been done before, what level of informal payments, amount of informal payments were before the reform. And then we made like in a couple of years, the second wave, actually to measure what are changes, and if any, at the level of informal payments for the primary healthcare level. Every time in this study and in the next study I will present, we were trying to look at the informal payments from the three sides. One side is the patients who are making informal payments. Another side is the health staff who might be who are providing services and might be demanding or requesting these informal payments from the patients. And the third side is the level of healthcare providers, like the facility where these services is being provided. So we're trying to analyze all of these three sides to receive like a complex view of informal payments. And you see that like in baseline study, we used interview with patients, with primary healthcare staff. We also analyzed financial and program data. We were trying to cover as many regions as we can, but unfortunately in all our studies as of now, we are not able to cover all regions of Ukraine because we have ongoing war and some territories are out of our access, so we cannot go there and measure informal payments. So this is kind of regional limitation of our studies. And also in follow-up study, which probably is worth to mentioning, that we used also the instrument of focus group discussion to maybe dive deep into some of the questions that we identified in our baseline study. So in focus group discussions, we also know that like patients or health staff are more open to discuss some of the questions maybe more deeply and providing additional background for us, additional insights to explain some of the results that we are receiving in the anonymous interviews with patients and health staff. some of the results. This is like very, very short results, because like the report is very huge, but something that probably like key highlights. So comparing baseline before the reform and follow-up study, we noticed that the prevalence of informal payments actually significantly decreased from 41.4% to almost 10%. We also saw that the percentage of those patients who are making informal payments for the primary healthcare level is also significantly declined from almost 62% to almost 21%, which can actually for us give a reason to say that implementing new financial mechanisms, of course, in a complex of all other measures like communication campaigns, more transparent communication and tariff setting by the National Health Service of Ukraine, autonomy at the provider level, that all brings us to the situation that patients are paying informal and informal payments less than it was before the reform. We also saw that the number of patients who are saying that we would like to willingly pay informal payments if there is such an official opportunity increases. And also we look at the like who are providing these kind of answers. So we understood that people who earn more, who said that we have a certain level of income, they are saying that they are ready to pay these informal payments officially if there is such an opportunity. We also saw that the healthcare providers improved their financial sustainability. They started to receive more money because now the funding from the National Health Service of Ukraine is based on the capitation rate, which is like for every patient who signed the declaration with the primary healthcare doctor, this amount of funds from the National Health Service increased, but also these primary healthcare providers increased the revenues from other sources because they are now more autonomized. They have an opportunity to attract money from other sources, like the local budgets, like donations, like working with international projects, also as well as like introducing paid services, which is out of not covered by the program of medical guarantees. That's also increased their financial sustainability. As well, the salaries of the primary healthcare doctors is also significantly increased. And this is not for this study, but for other studies as well. In 2022, actually, the government introduced a new legislation, which is setting the minimal level of salaries for doctors and nurses, which is also setting up some minimal wage for valuable professions in the health sector. And again, as providers has an autonomy to set up any salary system they want, they have the opportunity to increase also these amounts to the level of fairness at their particular healthcare facility. Our another study is actually about specialized healthcare level, but as we have like more than 30 packages in the state-funded program of medical guarantees for specialized healthcare level, we focused on 4 so-called priority hospital services in Ukraine, which is neonatal care, childbirth services, myocardial infarction, and acute stroke services, because that was set by the government as a priority ones based on the mortality rate, based on the some of the health outcome indicators, as we saw in the system, which was not so good as we wanted. So here we also have 2 studies, which is actually the same logic before the reform has been introduced and after the reform has been introduced. Before the reform, as you might notice, is something different from the primary healthcare level, because the reform at specialized healthcare level started on April 1st, 2020, which is later than for the primary healthcare level. Here you may also see that we also use very different instruments for collecting the data. We again apply the same logic. We ask patients what they think about informal payments. We also ask the health staff what are their practices or in the area of informal payments. And we also looked at the data of the healthcare providers, like who are providing the services. And as the second wave of this study we conducted basically during the full-scale war, we had not an opportunity to cover as many regions as for the primary healthcare level. So here you can see only 22 oblasts in Ukraine, and as you can see on the map, not all of them healthcare providers from the baseline study were included, so we substituted them with the similar healthcare facilities located in other regions, simply because these healthcare facilities might be located on the frontline regions, which is not safe for nobody to actually live and, of course, to conduct the study. But that's what we have. So we recalculated our baseline sample based on the new data that we have. Some of the very, very key results, because again, the report is very large. For all priority services, which are 4.1, you can see on the screen, we noticed that the prevalence of informal payments is declined. But if you remember a few slides before that, like for the primary healthcare level from 40% to 10%, here we did not see this dramatic change in the decline in the informal payment. There is a certain reason for that. Specialized healthcare level is not so easy to transform. Some of the financial mechanisms are still being transformed from the global rate to some of the like payment for service or payment for the case. So this is like ongoing change process. But anyway, they are decreasing. If we look at the amount of informal payment, it's also decreasing. It's actually far away from zero, but again, we saw these tendencies because of the reform and other anti-corruption measures has been implemented. Unfortunately, we see that informal payments of some of the vulnerable groups are still very high, and sometimes they are higher than average informal payments for a certain hospital services. But we saw also some of the positive signs as decreasing in the prevalence and decreasing in the amount. We also saw that the attitude of the patients and health staff remain very negative in formal payments. So we can say that we build this understanding that certain services are already paid by the government and there is no need to actually pay additionally, for example, from the pockets of payments for the same amount of services. And also what we saw in the study, that which is probably very interesting, as we asked the same, some questions were the same for patients and for the health staff. In baseline study, health staff usually say like informal payments, oh, we never saw these examples in our practice. We are not receiving any additional payments from the patients. But in the follow-up study, health staff were more open about telling the truth about informal payments. So in some of the results, we saw this like amounts of informal payments reported by patients were very close to what is saying the health staff. So the reform and other measures also have an effect on the openness of the health staff to fairly talk about what is actually happening while providing the health services. And that is a great evidence for the system overall, how the system is being transformed as well. And what we can like very quickly saw on some of the general high-level results, I showed you some of the corruption perception index before the reform. We occupied 116th place. Now we have a different place. Of course, again, this is a general corruption index for the whole country, not specifically for the health. But this is one of the measures which is showing what is happening in the country overall. And we saw this, that we are improving our place. It means that we are improving certain practices which are leading to corruption, and we are eliminating these reasons for corruption happening. We also saw that the amount of money which are spent by the government for the program of medical guarantees is increasing every year, with a small except for 2023, just because we have full-scale war era. Unfortunately, many other priorities, but again, the tendency is actually to increase spending, which means that providers will receive more money. They could spend this money for medicines, medical products. That is actually the answer from the patients, what exactly they are paying for, medicines and medical products, majority for the whole services. So there is a greater opportunity to cover these expenses by the government, which will eliminate also the corruption. And also every year, the NHSU is expanding the list of services which are covered by the program of medical guarantees. Every year, it's improving the contracting requirements to make it more clear, more understandable for the healthcare providers. And everything else which is actually a complex measure with many partners, many organizations, including our project, for helping the national stakeholders eliminate corruption. And we see that even with this very, very small range, like 6 years of reform being implemented in Ukraine, we already can notice some of the very positive changes. And as Ukrainians, we believe more to come, more positive changes. We are trying to build our system more stronger and more resilient, even during the full-scale war. Reform did not stop. We are continuing to do the reform and to support providers to provide services for our citizenship and to survive as a country. That's all I wanted to share from my side. Thank you so much. Дякую for listening. And if there are any questions, I'm happy to take now or during the panel discussion.
Thank you very much, Nataliia, for such a brilliant presentation. You know, we are often speaking about evidence-based medicine. Now we speak about evidence-based governance. So thank you very much for that. I believe that there are lots of questions to be addressed to Nataliia, but we will do it during the panel discussion because now another speaker of ours has limited time, and we'll have a pleasure to listen to the presentation of Dina Balabanova. So now it's a great pleasure of me to introduce you Dina Balabanova, who is a professor in health systems and policy at the London School of Hygiene and Tropical Medicine with over than 25 years of experience in research on governance and effective delivery models. And I'm sure that Diana will continue as a topic which has been started by our previous speakers. So Dina, please, you are given the floor.
Thank you very much. Can you hear me? Can you hear me? Can somebody give me a sign if it's okay?
Yes,
Okay.
yes, everything is perfect. Thank you. We hear you.
Thank you very much.
Presentation.
Thank you very much, Radmyla, and everybody. It's a real pleasure to be here today. I'm one of the regional board members of Health Systems Global, and it has been my incredible desire to do more in this region, to show more, to showcase the experience of countries. I'm coming from this region, and I think it's really important. And I'm so pleased that this conference is happening now. I'll just share my slides. So it's a real pleasure, especially the topic. In the past 10, 15 years, I've been working on issues around corruption and governance, and I think it's extremely important issue, and I'm glad to be part of this session. So first, I would like to raise the question, why should we worry about corruption and fraud in health systems? So you may think it's obvious, but I think there's been a lot of international debate, and there are those people who are saying, actually, there are certain things in a country that are linked to maybe social norms, maybe doing business, almost corruption. Sometimes informal payments could be seen as a form of doing business. So if we eliminate, say you have country where there is shortage of health workers, and health workers come to work and they expect to receive informal payment. If you are very strict and eliminate and sanction informal payments, you may end up not having health workers in post. So actually, it may get worse. So you have to think of the complex situation. And so we started with this, and there are a lot of these debates. So we did a lot of foundational work, which we have published, but I think this summarizes slide, and some of this has already been mentioned, but we found evidence of link of corruption on loads of things. And these are corruption, this is a big umbrella. It includes absenteeism, informal payments, fraud, procurement fraud. So this is summary of what's published, summary of the literature. So we know that corruption leads to worsened health outcomes, worsened mortality, under 5 mortality, decreased life expectancy, increase in infectious disease, AMR, mental health, or various other measures. We have evidence, there are evidence published that there is impact on corruption on decreased coverage, loss of resources in the health system. Interestingly, we published a study which is not confined to one region. It's a worldwide study of all countries that had data, which showed that countries with high level of corruption spend less on primary health care. So this is really interesting. This is the case also in high-income countries. So it is also skewing the priorities of the health system. Reduced responsiveness, they are also damaged not at the individual level just, but to the system as such. So if you pay informal payments for particular services, people may be, there are more practitioners wanting to work in those services, neglecting other areas. You may end up with absenteeism or inability to meet health system goals. And we see a lot of this in high-income countries, what the procurement fraud. So on Monday, I attended a very big launch of a report in the Parliament, in the UK Parliament, which is summarizing and highlighting the impact of corruption, procurement corruption during COVID. The multiple impacts, damage to the system, damage to public trust, to outcomes. There was a lot of, for example, companies who are not meant to deliver PPE, they supplied it, it was poor quality, it was not used. So the damage was billions, not millions, billions. So this, and the government has now established position, it's going to establish a position that was announced this Monday in the UK. They're going to have a minister, commissioner for corruption. It's meant to be for COVID, but maybe it will become ongoing. And this commissioner would report to the government. We are talking about, in some cases, 30% of the resources in the health system are lost to corruption. Up to, we don't know, it varies in each setting. So we do have enormous amount of evidence. However, we also see, and the previous presentation by Nataliia, I was really interested in that because I think we see the different impact on different groups. Actually, there are a lot of people in the population that benefit from informal payments. For example, those with more resources, they would go and pay, they may pay high amount, as Nataliia showed, but actually they may benefit from that. They may get disproportionate benefit because we know that even in many cases when richer people pay informal payments, they also have informal exchanges. They exchange favors, so they're treated, they get added value. So generally, this is, I think, summarizes why we should be worried about corruption in health. So I would like to discuss a study which was done with Petra Varhovny. She is actually on the call here. This is very much the work she did, the analysis, and I'm just presenting it here. This is, we started looking at what is happening in the countries in Eastern Europe. So these are countries that are largely democratic. They have a universal coverage or near universal coverage on paper, with extended primary health care, and so forth. But we see continued reliance on out-of-pocket payments. So what is going on? There are also reports of poor quality of care. Some of the outcomes, if you look at the outcomes of this region, health outcomes, they've not improved to the extent that you would expect. So we've been thinking, what about the corruption in this region? What can we think about? So we asked the question, what can we see a relationship? Can we do analysis between corruption, level of perception of corruption, and outcomes in this particular region? So the independent variable in the model, we used corruption perception index data, and then health outcomes. We used avoidable mortality and out-of-pocket payments. These are two of those. And then we had fixed effect panel data analysis of 12 countries, covering from 2012 to 2020. And we controlled for various other factors. So this is the model you could see more or less. Now, what was really interesting for me, even to see the frequencies of informal payments in this region, they are quite stable. So I would say it's quite interesting that although we look at out-of-pocket payments, when triangulating with other studies, we know that a lot of what you see here, out-of-pocket payments, part of it is informal payments. We don't know the data. We don't have the data for the countries, so we couldn't use informal payments. It's not comparable, but we use the WHO data here. So we see that in a lot of countries, despite reforms to improve financing, to improve coverage, we see, so a lot of these countries have done a lot to control corruption, and with a lot of opportunities to report or to do various checks in the financial system. However, we see that the out-of-pocket payments persist. So then as I said, the independent variables is the CPI, is the corruption perception index. It's a country ranking based on perception of corruption. Then we looked at avoidable mortality and out-of-pocket payments as dependent variables. And of course, we adjusted for economic growth, as we usually do. That's important. Government expenditure, GDP. And also we try to adjust for different political variables, because we hypothesized that maybe in countries, so imagine a country where Western European country and UK, for example, you don't have such a clear link between corruption and outcomes, because of the democratic regime and checks and balances neutralizes. Maybe corruption is very minor in its effect. So we adjusted for that. We also adjusted for various social variables, such as percentage urban population and Gini coefficient, equality, trying to think about whether health inequality in a country affects this association. So this is summary of our findings. We found that it's a very interesting situation, how there is harm. There is, of course, we cannot say causality. This is regression analysis. This is, although with panel data, you could make stronger conclusions. But so what we see is that lower levels of perceived, for avoidable mortality, lower level of perceived corruption, and stronger government accountability, more robust rule of law, decreases the avoidable mortality. So there is an effect. Then we looked at increased public health expenditure, also it appears to increase avoidable mortality, which we couldn't explain. Why would that be? So there were various hypotheses, and we were thinking that sometimes this is mediated by the quality of governance. So now the out-of-pocket payments, so lower level of corruption increased the out-of-pocket payments. So that's something that we, although we couldn't explain that why would this be the case? An increased public health expenditure decreases the out-of-pocket expenditure. So we see that the links between this is not very clear, but we have clear results for avoidable mortality, that there is a link with perception of corruption. So what are our conclusions? The conclusions are that sustaining investment into health systems is important. What we see is that a lot of the countries in the region have done a lot of progress in terms of expanding packages of services, but we see that something else is missing. There are concerns. So public surveys show that people are concerned about quality, people are concerned about accountability, responsiveness. The systems remain quite unresponsive in many cases, and people often feel they have to contribute. It doesn't need to be all informal payment. We know that part of it is informal, but the fact that people are contributing, and that's in the public sector. So this means that they feel the need to augment their care, to do something, to even to give gifts and various things. Clearly there is some gap in the system that we don't understand. And what's interesting is that despite different efforts to control this, things have not changed. And by the way, a lot of people would say we see in Western Europe equally high out-of-pocket payments in some countries, but I think the difference is that in Western Europe, a lot of these are mitigated by private insurance, but in Eastern Europe, this is a little bit less. So definitely there is an effect on out-of-pocket payments for financial protection. So then our biggest recommendation is that we need to think about incorporating much more accountability, transparency, and corruption measures into health system strengthening programs. So we see most of the health systems have procedures to ensure compliance with rules, but we don't have integrated measures for accountability and transparency and so forth. It's a separate thing always. So I think we need to integrate this a bit more, and this is happening very much worldwide. Maintaining sufficient public expenditure against situations of crisis or reduction in revenue is important. And digitization, clearly, and citizen responsiveness, but channels to ensure that people can respond. So these problems, as I mentioned already, are not just in Eastern Europe. So we have the problem of health sector corruption worldwide. The problems are incredibly severe, even in high-income countries such as US, Germany, Belgium, UK. So to really have a debate about that, we have convened the Lancet Commission on Anti-Corruption, which will be launched this year at the main Health Systems Global Conference in Nagasaki in November. So if you are attending, please come to our satellite session. But I think this is not going to be commission on corruption. This is going to be commission on anti-corruption. And I think the point is that we know very little of what works. There have been very few randomized control experiments or any other interventions evaluated in any way in health. Virtually none. We don't know what works. Formalizing informal fees doesn't always work. What has been shown is sometimes it captures some of the informal payments, but the informal payments continue. So we don't know. And there are a lot of unintended consequences of acting on corruption. So we need to have a proper discussion and create a platform where we can convince stakeholders and really think about what's politically feasible and practical. Finally, I'm finishing now. This is our framework. So I just want to mention something really important. We are not here this is not about moral judgments. And obviously, when we talk about corruption, I think in our team, in our work in the past 10 years, we are very clear that we are not talking about individuals. We're talking about changing institutions, changing the way the systems works, because individually people do things that make sense to survive. So it's not about catching individuals, it's about changing systems. So I think our feeling is that in order to really get the support of different types of stakeholders to talk about corruption, the only way to do that is to think about outcomes, that corruption really affects the outcomes. And there is already, as I showed, evidence on that. So we want to look at a number of things. Very often corruption focuses on individuals, their incentives. So why would people do it? Coping, or they do some sort of problem solving. Sometimes there is nothing in the facility they have to take, and maybe they take a cut of this. So there are all sorts of network issues here, why people engage in this sort of thing. However, we want to really understand a bit more about the nature of the health systems and what is it in the health system that can be done and actually promote corruption, but also the enabling conditions. We think there are many situations where crisis exacerbate what can be done in the health in terms of corruption, because as we see, corruption very often occurs and is exacerbated during crisis, and that's not because it doesn't exist in other times. It's because there are more opportunities, spaces open, which are new, and people exploit that. So I would like to finish my presentation. Thank you very much.
We've had another brilliant presentation. Thank you very much, Dina, for it. You've raised a number of very important issues. For me, as a lawyer, well, I should have said that I should say that it should be about liability, but no, not only, but mostly about what you've outlined, not only about legal liability, but about perception of corruption, about changing the mentality, about clear policies and procedures. So thank you very much for outlining so many issues and for all the stresses you've made. So again, yeah, applauses. Yeah. Very well deserved applauses, and I wish we have more time for discussion, but as far as I know, Dina has to leave, so if you have a question you are willing to ask right now, and you are willing to ask to Dina, please do it now.
I'm sorry, I was because we got a little bit delayed, so I have to go to another meeting, but I would love to answer any questions. And if you have any idea about any anti-corruption initiatives in your countries, of course, we're very aware of the anti-corruption initiative ProZorro in Ukraine. And we even have Dr. Suprun. She's part of our group. We're talking to her. So this is there, but I think we want to be more imaginative. We're in Poland. So one thing that I heard about years ago in Poland, they had in some hospitals very interesting initiative. They wanted to reduce the individuals taking money, and apparently they created some sort of common pot where people can contribute, and the money that were collected from patients were used for the whole clinic. So I just would love to hear any other initiatives or any other concerns that you have. But I just wanted to say that, importantly, when we talk about corruption and informal payments and all that, corruption generally, it's a worldwide problem. It's not just one regional. I mean, I think we have a problem. I would like to mention, I spoke to somebody, as we always say, in Sweden or Scandinavian countries, we have hardly corruption. And I spoke to somebody who told me the following, who is actually a lawyer who is working in Sweden, and saying in Sweden, if you look at the health system, no corruption, everything's just there. However, what has happened, the exposure of corruption has been moved to the legal system. So for example, you don't have health system governance experts who are dealing with corruption. You have lawyers dealing with corruption. There is corruption in healthcare. In Sweden, for example, they've set up with monies for refugees, they've set up fake diagnostic centers and things like that. But if you look at the health system, it's not reported. It's seen as a crime, as a part of the criminal. That's why I think the only way to cope with corruption is to look beyond the health system. So, Nataliia, you wanted to ask?
Actually, not to ask, maybe to contribute for your question, what other initiatives? I just understood that our project also supported the introduction of one of the legislation, which is not directly about anti-corruption, but it's part of it. It's creating of supervisory boards. For my Ukrainian colleagues, it's naglядові ради. So this is one of the instruments which brings more transparency to the level of healthcare providers, because this supervisory board is actually consists of representatives of civil society, of patient organization, of the owner of healthcare facility. And this is actually a very good tool to look and discuss with healthcare providers what can be improved. And this is one of the tools also for the patients, for example, to raise their voice about the questions that they are concerned, and that could be fixed at the level of healthcare providers. We just started this process, so this is like something work in progress. Only a few supervisory boards create, so we cannot talk about like the results, but this is already here. This is one of the tools, very fresh initiative in Ukraine, and I think like in a couple of maybe months we can talk more how that actually works here in Ukraine. Thank you.
I mean, this is brilliant, and I just wanted also to say that we have at the moment, it's part of Health Systems Global, it's a working group on accountability and anti-corruption. We just launched this month crowdsourcing of ideas, and we have won award attendance of the conference in Japan. So if anybody wants to contribute, please can you email me, and I will send you how to apply, you could submit your idea, your experience.
Okay, thank you so much.
Thank you very much, Nataliia, for such a valuable comment. It's extremely relevant. And Dina, lots of thanks for your presentation. You know, we in Ukraine are very lucky that such professionals as you work for Ukraine, help us get rid of corruption and increase healthcare system performance. So we hope we will be able to cooperate with you in future. Thanks again.
Thank you. But I just want to say that in a way, not we helping you. I think the ProZorro system that was developed in Ukraine has been disseminated to a lot of African countries, and we keep making presentations. So Ukraine is helping a lot of countries. We should not forget about that. That's the only good system we have that has been properly tested, and it has a good impact. I'm aware of a few studies, decrease in informal out-of-pocket payments and all that. So there is enormous interest. So I think you should not forget that you are helping a lot of other countries with your experience. And thank you very much.
Great, thank you.
Good conference.
Exactly. Well, we are very thankful to all organizers and participants, and lots of interesting things are ahead. So now I have a pleasure of giving the floor to another speaker of ours, Dr. Ismail Anas, from, let me open your presentation, from the Alliance for Health Policy and System Research. And Ismail will, as far as I understand, will tell us about will tell some success stories, some real life experiences. So Ismail, please, you are given the floor.
Thanks a lot, Radmyla, and thanks for the previous speakers for their presentations and the interesting work that they've done and they're doing. In my presentation, I'll be talking about some of the work that we have at the Alliance. I'll be talking about a project that we've completed that is very relevant to what was discussed. And then I'll talk about two other projects that are ongoing. One will be happening in Ukraine. Just to start, I'll give a brief background on the Alliance. So it's the Alliance for Health Policy and Systems Research. We are an international partnership that is hosted at WHO headquarters in Geneva. We work to advocate for an advanced health policy and systems research. We work on generating evidence that is used to catalyze policy changes. And we also work on building health policy and systems research capacities, both individual and institutional at low and middle income countries. For example, in 2023, we've supported 260 publications. A lot of these are led by female authors as the main authors or the first authors. We've helped develop 7 frameworks or tools. We've supported 107 research grants, worked with 36 collaborations, and influenced policy in countries in 26 instances. And we've just recently launched our new strategy for 2024 to 2028 with 5 focus areas. The first being universal health coverage through a primary healthcare approach. Second is working on digital transformations. The third is on NCDs. Fourth is on realizing the co-benefits of working on climate change. And the fifth, which is also relevant to the current conditions in Ukraine, is working on health emergency preparedness and response. So the first project that I'll be talking about, and is very relevant to what was discussed by the previous speakers, is a project that was started, I believe, in 2019, and then ended recently with the publication of a supplement, as you can see. The work was on trying to understand how initiatives, whether done by governments or whether done by NGOs and community groups, were successful or not in making health insurance programs more responsive and more accountable to the citizens that they serve. The program was done in 6 countries. Most relevant to our meeting and the countries we're interested in is Bosnia and Herzegovina, where we looked at the patient protectors for health insurance entitlements agency, which is, I believe, is a governmental agencies. And we've also looked at the family medical teams and their role in information provision and supporting providing navigation support to their patients. We used a content context process Molyneux framework to understand in each of these 3 domains what was an enabler factor or what helped the initiatives achieve their goals and objectives, and at the same time what factors hindered or prohibit or did not allow these initiatives to achieve their intended goals of achieving more accountability and more responsiveness to the citizens. What we found is that for the governmental initiatives, they were mostly had good intentions and reflected very real and true efforts from the governments to increase the voice of the citizens and, for example, setting priorities for what products or what services are covered by the health insurance programs, to provide practical support to the citizens to know more about the programs and to access the entitlements that they can enjoy by the government health insurance. But at the same time, we found, for example, in the content, we found some factors that did not allow these governmental initiatives to achieve what they were set out to do. So, for example, there was misalignment of the design with the function. So, for example, one example that I can bring from going back to Bosnia and Herzegovina, the BBHI was supposed to channel grievance redressals of the patients in case they were not able to successfully benefit from the entitlements that were given to them. So that was the function, but then the way the BBHI was set up and was designed with shortage in resources, with power imbalances between the different offices, did not really allow it to do that function. We've also seen conflicts of interests. For example, in Colombia, the government mandated the health insurance companies to provide their members with letters of performance to show how they've performed over the years, what services they cover, and how they rank in relation to other health insurance companies. But of course, now we can see immediately a conflict of interest in that the health insurance companies would not be motivated to show real figures or real to reflect the reality if they're not doing better or if they're doing worse compared to other companies. In terms of context, we've seen that sometimes the governmental initiatives did not pay attention to the literacy and familiarity with digital technology of the people that they are trying to help. So, for example, in Ghana, we've seen we've looked at a mobile renewal platform which allows people to renew their health insurance registration by going through, by using a mobile application, but that had problems with people who were not able, first did not have a phone, second had a phone but did not have enough digital literacy to navigate the application and make online payment using the online wallets that people have in the country. Another context-related factor was the beneficiary expectations and apprehensions, and this also brings us back to Bosnia, where the history of conflict in the country made people have lower expectations than one would think, and so even if they had problems or they had grievances, they would not really address them or they would not really report them because they were apprehensive that they would be singled out by the officers or the medical providers as troublemakers or as negative people, so they would not enjoy the services that they could enjoy otherwise, and that really hampered the use of that initiative. And then we could see power imbalances between the different actors. So again, going back to Colombia, and one of the initiatives that the government set was to get citizen input in priority setting in terms of what the insurance covers, but that also brought a power imbalance between the pharmaceutical companies who have interest in getting their products covered versus the opinions or the input of the citizens themselves. So obviously we could see power imbalances that affect the process and the initiative. Third, when it comes to the process of implementing these initiatives, one thing that we saw is that when first we talked about initiative design not being aligned with its function, but sometimes when both are aligned, what the problem was that at the implementation stage, there was not really fidelity to that design. So that also ended up in a situation where the initiative was not really doing what it was supposed to do. Another process factor was the shortages of resources. And here we talk about the human resources, but also material resources. One example that I could bring from Nigeria was what they call the national desk officers, who were supposed to, they are officers from the National Health Insurance Agency, and they were supposed to go to one big hospital and 6 peripheral hospitals to receive grievances from the patients, to provide information and navigation support. But then the number of officers that were assigned were very few compared to what is needed, that at the end of the day, the initiative was not really implemented. The officers would only stay at the big hospital. They would not have time to go to the peripheral hospitals. And even at the big hospital, they would not have time to receive or manage all the input or all the grievances from the patients that they were supposed to serve. And then a third process factor was the lagging databases and networks when it comes to digital initiatives. So the mobile renewal platform, we've had a look also at other digital technologies implemented in Indonesia, and they've all reported either lags in the database update and synchronization between different databases. They've reported issues with access to data from other institutes, organizations or government bodies that were related to the health insurance entitlements, but were not given the authority to access data for patients. So sometimes patients would go to those organizations, but their status in terms of having an active membership or not, or in terms of their payment, having a full payment or not, was not really reflected in real time, or the organization would not have access to it. Now, moving on to the non-governmental initiatives, they were more characterized by being flexible, by emerging organically to fill some of the gaps or some of the problems that I've just described with the governmental initiatives. So for example, when it comes to the content, the non-governmental initiatives generally had a broad range of support services, so that went beyond healthcare. So for example, in India and Gujarat state, we looked at an informal informal employee network for women in the informal economy, who previously given support to those women in all sorts of governmental services. And so the health insurance services, that support services that were given, were just an add-on to the previous package of services that were provided. And that allowed them to deliver, to help the women more readily, or to be also embedded in the employees' communities. With the same example from India, because they've had this long history, this broad range of services that they've usually provided, they had a history of being embedded in the community with centers in villages or rural areas, and sometimes even going on home visits to the people who cannot come to their centers and offering the help there as well. In terms of context, we've seen non-governmental initiatives being flexible in terms of their communication with their beneficiaries. So they've used social media platforms such as WhatsApp or Facebook to reach out to their beneficiaries and to the people, and also allow the people an instant way of getting in touch with them, and so removing all these bureaucratic barriers that would otherwise be with the governmental initiatives. And the second contextual factor that we found out about was that the underlying motivation for the employees and the volunteers who were working on these initiatives. So, as I said, these were kind of organically emerging initiatives, and so they were really motivated by the employees were really motivated by what they've seen in terms of the problems with the governmental initiatives, and they were self-motivated to help their fellow community members. When it came to the process, one thing that we found out is that the more organically emerging the initiative was, the more successfully it implemented its functions and achieved its goals of helping the community members access their health insurance entitlements. And the longer they've worked with the community, the more they enjoyed pre-existing trust. So, for example, in Bosnia and Herzegovina, we looked at the family medical teams, who are at the first point of contact for the people to access healthcare. And so the people would actually ask these medical doctors or these medical teams for information about their health insurance entitlements, for how to address or how to lodge their grievances, how they can be referred to other services, and all these things that were otherwise should have been provided by the protector of patients' health insurance entitlements, just because the patients felt that they were dealing with these medical doctors for a long period of time. They were their first point of contact with the health system, and they've enjoyed a long history of trust with them by seeking healthcare from them, that they felt they were the ones who could help them best. Now moving on to the second example of projects that we're currently working on national public health agencies as governmental institutes in the wake of COVID-19, to see how they can be best reformed, how can they best perform their functions in terms of preparing for the next pandemic or epidemic and responding to it in real time. One key factor here is that this particular research is very much driven by policymakers. We're working with 13 countries, or 13 national public health agencies in 13 countries. And we've had either the head of the NPHA or a very senior person in the NPHA in a meeting last May, where they told us about their experiences during COVID and other public health emergencies. And they've told us about the questions that they want the research to answer. And these 5 areas that I'm listing here are the main ones, more related about the role of partnership and dialogue, particularly with other governmental institutes, with other governmental ministries, and how they can work together and partner, particularly in terms of in times of health emergencies. They want to know more about the legal mandates the ones that are written, de jure, versus what happens actually on the ground when there is a public health emergency or a pandemic. They also want to know more about how the NBHAs can evolve and reform, particularly in federal systems. So countries that have federal systems where states sometimes have have the responsibility for healthcare. And the fourth topic that they want to talk about is the relationship between the NBHA and the Ministry of Health when the NBHA is not part of the Ministry of Health, when it is a different or a separate government agency. So how they can talk to each other, how they can implement public health measures together. And the last one was about leveraging research and evidence, particularly partnering with academic institutions in their countries to know how to access the research and evidence that they're producing and make it more responsive to the needs of the policymakers. And then I'll finish with this project that we are now starting, which is Health Policy and Systems Research in Chronic Conflict Settings. The idea is to generate evidence on what service delivery models work best in chronic conflict settings, such as what Ukraine is experiencing at the moment from 2014, but more in this active phase since 2022. The focus, besides Ukraine, we're also working in Somalia and Yemen. We're also adopting a co-creation approach where we're asking for research teams that must include policymakers, so that the policymakers can help guide the research questions, and as well as the research process itself. In fact, a couple of days ago, I'm happy to announce that we've launched a call for expression of interests for research teams based in Ukraine. And particularly in Ukraine, the theme that we're looking at is how we want to see what reforms, such as what has been discussed these couple of days in this conference. So how these reforms that happened from 2016 onwards, how they've helped the health system be resilient, particularly in this active phase of the war since 2022. So what policies were made, what adaptations have been made before this active phase had started, as well as during. So over the last couple of years, what changes, what policies has the system in Ukraine made to help it still continue to deliver services, particularly to the areas that are most affected by the current war. So I highly encourage you all to look at the call for expressions of interest. You can access it using this QR code. And if you're a researcher based in Ukraine, please do submit an expression of interest to us, because we're really looking forward to doing this work with Ukraine, which we're doing with in partnership with the WHO country office in Ukraine and in collaboration with the Ministry of Health as well. So thanks a lot.
Thank you, Anas, very much for a brilliant presentation and for this call for cooperation. It's really important. And now it's time for the last presentation in this session. And the last presentation appears to be mine. I will try to speak very briefly, but at the same time, I would like to raise the question, actually, to speak about the introduction of healthcare professionals' self-governance in Ukraine, in terms of accountability, in terms of transparency, and certainly in terms of inclusion and healthcare professionals' empowerment. Well, but before doing that, I should tell you that what I've brought with me is the spirit of resilience of Ukrainian healthcare system, of our people and of our universities, the Taras Shevchenko University of Kyiv, to which I represent, and the Kyiv Medical University, to which I also have an honor to belong. So, unlike many European countries, Ukrainian healthcare professions are solely regulated by the state. Currently, we don't have such an association like, for example, Naczelna Izba Lekarska in Poland. And it is an important point of our agenda to introduce self-governance of healthcare professionals. And you may be surprised that this, oh, thank you. You may be surprised that this is a point of the agenda of the Ukrainian recovery plan. Why is it included even in the Ukraine's recovery plan? Why now, during the time of war and the recovery from consequences of this war? Because this issue is extremely important, and I will show why it is extremely important for to improve Ukraine's healthcare system performance and health outcomes. You know, yesterday during networking, during the discussion which I had with Elina, she mentioned that in one of the project she carried out, they got the remark, and what is the opinion of Ukraine's healthcare professionals? And what is the opinion of Ukrainian healthcare professionals? There is no joint opinion of Ukrainian healthcare professions. Why? Because there is no organization that would represent the whole healthcare profession, medical profession, pharmaceutical profession, etc. We've already talked about healthcare reform, which Ukraine undergoes, and this has been a drastic reform. And you certainly know about the consequences of the impact on Ukrainian healthcare system. Here is the updated slide, and I updated it tomorrow's morning. And unfortunately, every time which I use those figures, they are unfortunately higher. It is important to mention that there is some reduction of healthcare workforce in Ukraine, reduction in number by nearly 14%, though at the same time, many healthcare professionals have been at their places. And despite of all hardships brought by the war, our healthcare system survived, remained manageable, and generally capable of providing healthcare services. And this is to a large extent due to the dedication and professionalism of Ukrainian healthcare professionals. But there is a pressing need to rebalance the power across the state, across the healthcare professionals and civil society, in order to ensure that healthcare professionals are heard, that their work is transparent, and they become truly accountable before their patients, before the society, etc. So introduction of healthcare professional self-governance is an important tool for in helping to meet state and societal expectations. Well, how can I go to the next slide? What is the current situation? You probably have heard that there are lots of associations of, for example, dentists, surgeons, etc., etc. But they're NGOs. They are not public professional organizations like Naczelna Izba Lekarska or Ukrainian Bar Association. We as lawyers have such an association. And what are the implications? The state may not delegate its functions to the NGOs. And what are the functions and why it is so important? First function is access to the profession, setting up the requirements for the profession. The second important function is certainly determining professional standards, ethical standards, and participating in determining the standards of provision of healthcare, medical standards. As to ethical standards, situation is extremely important. Because currently, for example, we have a number of codes of ethics, but those codes of ethics are mandatory only to the members of the professional associations that adopted those codes. For example, the Code of Medical Ethics was adopted by Ukrainian Medical Association and some other associations. and it is mandatory. It extends only on the members of those associations, but not on the whole to the whole profession. Of course, we may use it to show what norms are considered to be customary ethical norms, but still, it's not that level of ethical standards and enforcement of those standards. So the decisions of those NGOs are not obligatory to their members only. And while speaking about healthcare associations, I will just give you one example. Let me have a look at it. It seems to me I deleted the slide. For example, in dentistry, we have more than 90 professional associations. Just imagine 98, it seems to me, so professional associations of dentists. Is it possible to agree on common rules? Is it possible to enforce the abidance by those, for example, ethical rules? I believe that the answer is evident. So the first such situation is certainly should be changed. Let's have a look a little bit on those issues. So the next issue is disciplinary practice. Is there any disciplinary practice? No. And you may wonder, what consequences will happen if a medical professional, if a medical doctor severely violates ethical norms? Unfortunately, according to the current legislation, he will continue being a doctor unless he is convicted for committing a crime, a criminal offense, not an ethical violation, but a criminal offense by the court with proper conviction, with proper sentencing. Unfortunately, those medical professionals, there are not so many such professionals, but still, if they commit serious ethical violations, they still can practice medicine. Is that situation acceptable? I believe the answer is also evident. And certainly, representation of the voice of medical professionals. Medical professionals should be heard. That is why if we sum up those issues, access to the profession, ethical standards, participation in determination of medical standards, calling to disciplinary sanctions, continuing medical education, and setting standards for continuing medical education, and representation of medical profession. It is evident that there should be a medical association, public law association with delegated power from the state, like in many foreign countries, like, for example, Naczelna Izba Lekarska in Poland, etc. So what we have currently, decides on the issues of access to the profession and registration. Currently, there is no individual licensing of medical workers. And who can practice medicine in Ukraine? In order to practice medicine in Ukraine, you should be either registered as a private entrepreneur and get licensed to medical practice, or be employed by a healthcare institution, by a healthcare provider, and also get the so-called license for the conduct of economic activity on medical practice. You may not practice medicine individually if you are not the so-called subject of economic activity. What are the implications? Lack of autonomy. If you are, for example, a surgeon, like Dr. Jurek Bednarski, and if you are invited to make a surgery in Lviv, in Kharkiv, in Odessa, in Poltava, in Dnipro, it will be very problematic for you to do it legally, because you can be employed in one place and you can also be partly employed in some other places, but not in many cities, in hospitals located in which may invite you to make a surgery. You may even get a license, but this license is linked to the premises in which you can provide your surgery. That's why your autonomy and your possibility to provide a highly qualified service to your patients is limited. So this situation definitely needs to be changed. And it is not possible to establish individual licenses as another regulatory profession. It is not expedient without professional self-governance. Another thing is continuing medical education and attestation. Who currently decides on continuing medical education? It's state organs. I very much like the slogan, nothing for us without us. But it's definitely should be more involvement, more inclusion of medical professions to decide on those standards. Another adherence to medical professionals' rules of medical ethics. I have already commented on this, and this is probably one of the most important things, because medical professionals should be accountable first before the issue should be considered, for example, by their medical chambers, by medical professional organizations, and then, if cases necessary, brought to courts, etc. Like, for example, it is done in Brazil. It's economy of legal procedure, of time, of money, etc. Contributing to medical standardization and increasing the quality of healthcare. These are, first of all, medical professionals who should take active part in creating the standards. Another thing is consideration of complaints, calling to legal liability. I briefly outlined those issues. So there is a pressing need for comprehensive regulation. The regulation which will allow medical professionals to be really involved. There has been several attempts to introduce such a regulation since Ukraine's independence. Many attempts. Why did they fail? For various reasons, starting from purely technical reasons and up to the absence of political will and reluctance of a part of medical community for those changes. Now it seems to me that everybody feels that the changes are needed. Another thing, what changes? What are those changes and how they should be implemented? So currently, the Cabinet of Ministers of Ukraine submitted the draft law on self-governance or self-regulation in the sphere of healthcare that was adopted in the first reading. It now provides a mandatory framework for self-governance of healthcare professions in Ukraine. It establishes 5 chambers for medical professionals, for medical doctors, doctor specialists, for GPs, for dentists, for pharmaceutical professionals, and for nurses and midwives. And those chambers make up of representatives from relevant medical professions. What are their key functions? The one which currently lack. So publicly available and registered. Do you know how many medical doctors are in Ukraine? How many midwives are in Ukraine? Nobody will tell you the exact number. So it is extremely important to have such a registry and to make it publicly available. For example, every person can have a look at the registry of an advocate and can learn whether this person is admitted to the bar or not. But we cannot do this with a medical professional. We have no information. What is the specialties for medical professionals, whether he or she raised his professional qualification, etc. So this is extremely important. Maintaining professional standards, both clinical and ethical. Working with relevant institutions, setting up standards for medical education and continuous medical education. Cooperation with other bodies, and certainly participation in development of legislation, in development of regulations. Nothing for us without us. And I will try to link it with our discussion and with the next session, how scholars can contribute to, can influence those policy changes and legislative changes and their implementation. For example, there is a project towards the self-governance of healthcare professionals in Ukraine, a joint project of the Taras Shevchenko University of Kyiv and Edinburgh University, and at least two of those surnames are already familiar to you, which is Mark's and mine. And I'm very thankful to colleagues Mark Hellowell, Annie Sorby, Edward Dove, and Ruby Reid-Berendt from the University of Edinburgh, because they allowed to see a bit larger perspective, a bit different perspective. Because implementation of healthcare professionals' self-governance is a journey. In many countries, is a very long journey. We just stepped in, and we have a chance not to reinvent the wheel, but at the same time, we have a chance to use the experiences, the best experiences and best practices of foreign countries. What are the key areas which emerged from the discussion with the stakeholders that we conducted and from our subsequent research? First of all, the purpose of the reform should be extremely clear, because even medical professionals often ask, why should it be done and why now? This should be clearly communicated to healthcare professionals and to other stakeholders, to patients, whose voice should also be heard during the time of design and implementation of this reform. Tackling political interference and corruption. Again, it's about anti-corruption. How this could help to tackle corruption, to get rid of corruption, or at least to minimize it, but not to create another grounds for corruption. Because if, for example, you read the anti-corruption expertise of this draft law, they saw some drawbacks that to some extent can be a bit dangerous in terms of some possible corrupted practices. That is why, while tackling corruption, it is important not to allow any potential corruption actions. Certainly, transparency of those processes and public accountability. And what is it for? What for it is done? Certainly for securing the right to health to all the patients, and the right to profession of healthcare professionals. So. We suggested some policy considerations to the Ministry of Health, to the stakeholders, which include communication of the purpose of self-governance, which concentrate on the necessity to consider which powers should be delegated and to clearly define those powers, which seems to be extremely important. And also, it should be the consistency between those chambers. The professions are a bit different, the chambers could be different, but there should be consistent in most important things, for example, in terms of ethics, etc. So I'm by saying all this, I am finishing my brief presentation, and I'd like to show that there are very many issues, even some regulatory issues appear to be the issues of health, actually they appear to be the issues of health governance, the issues of transparency, the issue of participation, the issue of anti-corruption, and certainly the issue of healthcare for all. So thank you very much for your kind attention and for your patience and for your interest. And now an extremely pleasant part for me, which is giving the floor to the panelists, to the speakers, and to the contributors who may wish, and I'm sure that they will wish, to ask questions or to comment on the issues that have been raised during our today's discussion. Oh, yes, please. We have a representative of Poland, Jerzy Bednarski, who is a medical doctor and also a governor for Poland at the World Association for Medical Law. So, Dr. Bednarski, please, your comments.
Hello. Good day. Dzień dobry. Dobry dzień. Happy to be here. Thank you, Radmyla, for great moderation of the session and for very important speech. So I totally agree. In fact, I work in the Polish Chamber of Medicine, Naczelna in Izba Lekarska, in fact, in Lublin, Izba Lekarska. And in fact, the chamber can help to solve most of the problems. As it takes care of the registration, it takes care of the ethical problems, and it also gives the second opinion. In fact, it doesn't create the law, but it helps me, it helps my friends to create the opinion, to say what do medics need. And in fact, they are all the time in the medias. They work very hard, and each of the doctors can contact the Polish Medical Chamber, and in fact, each of one can contribute to the work of doctors. So implementing chambers in Ukraine should be quite beneficial. Thank you.
Thank you for your comment, Jerzy, and please, Nataliia.
Thank you, I'm Katerina. Well, thank you for inviting me to decorate this scenery. And it was music to my ears to hear the esteemed colleagues. And if you let me do so, I will just probably walk through the pitches that were delivered before. And firstly, I would like to address to Simon's talk, because his delivery of political determinants of health, they actually become a continuation of yesterday's resolution over social determinants recalled by Elina. And we can observe that democracy and health is not only something about a burning issue in the US. We can observe this echoing in the European Forum of Goldstein, which is expected to be in the upcoming weeks. So we also see this huge connection. So there is a necessity to discuss this in a broad sense. And then I just, like, from my perspective, to add on this, we can see that Ukraine does not have some of these minimal conditions put in place, which was outlined by Simon. So just we do not see universal elections and regular competitive elections under the obvious conditions, but still it's a kind of some threat. As we can see, and also some openness in communication is also under the threat. Then I was impressed by the talk by Dina Balabanova. So I guess she was masterfully added evidence in favor of that. We can put a responsibility for the health outcomes, such as avoidable mortality, not on the health systems only, because we can see them reflect the political rule, and this is the place where accountability should come into place. And also, I guess that Dina led us towards the enabling conditions, like in a broad terms. So we're just not only concentrating in our narrow space, we're just moving further. And what else I would add is just Elina Dale, she was talking partly with regard to transparency, that it just lets us minimize the fraud. And this is how we just reach this idea of professional regulation. But I would like to admit that self-regulation, self-governance, it's just one type of the professional regulation, which was outlined by Jurek. So it's across Europe, if you even compare the countries, there is such a balance. It's a delicate balance between what is the space that is occupied by the government and which is occupied by the public societies, professional societies. It's always the talk, it's always the discussion. So it's not, we say, we're just giving everything to the public. No, it doesn't work this way. It's not like an open market will regulate this. No, it will not. So then I would probably also move to Radmyla say. So my assumption is that the context of the self-governance in Poland is deeply rooted in this Solidarność trade union, if I'm just spelling right, sorry if you correct me. So if we may just look through the historical lens, that Poland is well known for the mobilization of citizens, and it also might set some professional context to this. So it's a kind of a landscape. And Further, I would like to emphasize that it was such a pleasure to listen to Nataliia Kovalenko, because it always my pleasure to listen to the colleagues. Indeed, I also work for the USAID Health Reform Support Project, but it's my part of health workforce planning. So to add on that, I could just say that this dimension of fair payment and informal payment, it's also echoes to what we've learned yesterday about the skill mix. So if we can see that we have in Ukraine let's say too many options ratio per patients, they will never give their part of the job to the midwives, because there is some part of the interest in doing so. And now we can see it in the figures, as we can see a more drastic drop in the out-of-pocket payment on the primary care, and there are not so significant changes in the secondary care. So I'm not just addressing to this kind of a medical service specifically, but it's just kind of a hint how it's happening behind the curtains. And last but not least, with regard to the Ismail, if I'm just spelling right, for your talk, you elucidated like this global problem when governmental and non-governmental organizations, they do not have understanding how to build this lesion. So one of them, they're not tracking them, how to find them. And I guess I probably just a little bit be provocative, I would address to Gary Aslanyan. So just, if you don't mind, give you a hint. So I guess you're doing a great job in building this kind of global health diplomacy to show how it should be done on different levels and even this top profile level. So thank you, that's all from my side.
Thank you for a perfect summary. Actually, you've done a part of our job.
Sorry.
Thank you, that's perfect. And I'm sure that there are some more people who would like to make comments both in the room and online. Do our panelists wish to comment, make comments, remarks, conclusions? Elina, would you like to do you have Nataliia, I'm sorry, I didn't see. Nataliia, could you please comment? Could you please unmute Nataliia?
Oh, yeah, it's not allowed for myself to unmute, so only the host could do that, so I was waiting for that. Yeah, maybe just like a few sentences. I think this panel actually is very good showing that any anti-corruption like idea is not something like one in national institution or one like person could do. So it's a multi-level approach, and there is definitely a lot of experience across the world that we can learn. But even our presentation representing very different dimensions of anti-corruption policy, and probably that would be like a question to all of the panelists, because here in Ukraine we do not have so-called like official document adopted by the government called anti-corruption strategy or something like that. I think like you, Radmyla, said that self-governance is somewhere in the recovery plan. So we have a lot of different level of documents. There is no anti-corruption document. However, this is a cross-cutting topic in many documents that we have. So I wonder maybe someone from the audience have this kind of experience that might be relevant, because for me, that's my personal opinion. It's very important to gather in one place all of these measures. Of course, this kind of events is a great opportunity to discuss all of that, but there should be also like maybe a joint platform where we can discuss like anti-corruption. We should clearly know who should be our like audience, with whom should we discuss all of that, as well as like certain topics, like definitely governance, definitely financing, definitely like service delivery if we are talking about health system, as well as transparency, like digitalization, and many other topics. So I think that we have like make this a very good summary in our presentations of these very different points of view, but also of this platform might be a very good discussion. Thank you. Over.
Thank you so much, Nataliia. Elina, would you like to comment? Would you please unmute Elina and be ready to unmute Mark?
Thank you. I think Simon actually had his hand first, so why don't you first give the word to Simon?
Oh, no, you go. I was just queuing up, so you go first.
No, I was just basically, I think there are a lot of different kind of issues, so even if we're all speaking around the same topic, have been discussed at this panel, and at different levels, as some of you have said. And I think one question that I still kind of have in my head, right? If we all agree with each other, okay, corruption is bad and we need to be more open and transparent. But I think what I realized with this work that we've started is when you start thinking of how to actually do it, right? Okay, so we have to have more citizen voice, let's say, when we are developing or looking again at the program of medical guarantees, what should be the priority packages, what should not be the priority packages, let's say, if it's in Ukraine. But then how to do it, the practical matters become actually quite difficult. And I think at that point, I just recently, when we were having those discussions, we with WHO and the World Bank and some of the colleagues, that I started trying to look at the kind of the details of how exactly we do it in Norway, how do you do it in UK for specific decisions, right? And that's when I think it really becomes a bit hard. I think one opportunity, for example, that Ukraine has, and which I think was not utilized to the extent that it could have been in the previous years, is I forget the exact survey now, and I will have it cited in our study. It's conducted regularly, and it asks standard sets of questions on various reform aspects. And I think that survey was conducted during the 2017-16 reforms. And then they would ask questions, for example, do you think that we should have co-payments in the progress part of the program medical guarantees? Or do you think there should be kind of the system where your access to health services does not depend on your financial contribution? And there would be answers, right? But what we found that those kind of surveys were not as much utilized as they could have been by those taking or making the decisions. And also, while there were some contradictory answers, as it sometimes happens when you survey people in a very quick answers and questions, that there was opportunity to follow up on those kind of somewhat contradictory signals from the population, which showed that people did not fully understand, let's say, or interpreted differently the word insurance, for example, the concept of insurance. And there was a room to engage with the people based on the results of that survey. But that was not done because of whatever reasons. And so I think there was a question about these very practical ways of what we can do better this time. And I think those things I was thinking of that we can use. There are things that are already in place in Ukraine that can be used more effectively. And the same goes with the supervisory councils that have been put in place that were also referred earlier. Over from my side.
Thank you very much, Elina. Mark, would you like to comment to sum up?
So I should give way to Simon because I think Simon had his hand up. Yeah.
Well, I'll go now. Okay. Yeah, thanks a lot. It was super interesting listening to all the talks. I mean, it was very enlightening for me, especially because of the regional issues that I'm less familiar with, and kind of amazed, given the circumstances in Ukraine, that we can have this kind of discussion about delivery of healthcare and do research, evidence-based research on this is quite phenomenal. So it kind of raise the question of, what do we do during times of crisis, whether it's a pandemic or war or a natural disaster of some kind, because the rules of the game change a bit. The healthcare system turns into, how does it operate in these conditions, and how does the political system operate as well? So these two things at the same time, maybe the usual approach has to be modified because of necessity. You can't have pure democratic conditions momentarily, because that may not be the right effective response given the circumstances. So that's a major challenge. And then for that reason, I had a question for Elina that, the kind of normative political philosophy stuff, which that's my background. So that was great to hear. It requires, this kind of deliberative democratic context, whether it's local government or healthcare professionals or on whatever scale. This by definition is meant to be a slow reflective process. But we can't do that when there's a war happening or there's a pandemic. So does that mean a deliberative approach is not feasible, or does it mean the emphasis is now placed on planning, hopefully for these events that don't happen but might happen, such that there's already a deliberated policy response ready and waiting? I don't know. The other thought I had was about corruption, which Nataliia worked on as well. There's the perception of corruption, and then there's the actual corruption. And both are really important, it seems to me. Maybe I'm wrong, because if people perceive that there's low corruption, that really means they trust the system, they're willing to participate, they're willing to pay their taxes to fund the system. But there could also be, a mismatch between the perception and reality. The reality is that there's less corruption, or that there's more corruption, but in some contexts, maybe autocratic, it's very hard to find enough information to detect corruption. For example, the Johnson's government's, the case of the PPE payments, maybe you wouldn't find out about that in some countries. You just wouldn't know. And in that case, they did lose the election, partly because of such things, and partly because the media became aware of it. But in some other contexts, the people don't know, and therefore the perception may not match the reality. But so that's a curious. Both are important, it seems to me. That's my thought on this. Thanks a lot. Thank you. Thanks for everyone for the talks, by the way, once again.
Thank you, Simon, for your valuable remarks. Any other remarks? A remark from Mark? Elina, yes, please. It's an answer, it's a remark.
Maybe I should let Mark go, but then I could answer Simon's question a bit, or at least reflect on that.
Yeah, so I know Elina needs to go in a few minutes, so I wonder if rather than a comment, I can ask a question, which is the opposite of what people like me normally do. But yeah, I think you've already been asked a really tough question by Simon, Elina, but I also have quite a tough question, which I can't help but raise, because I think it's really important. So actually, Elina, in a lot of your comments over the last couple of days, you've been pushing us to think about the how, but how questions are often quite context specific, which is one of the challenges that we face when we try and generalize from case study evidence, for example. But so in Ukraine, there is a process of democratization, and especially since 2014, and even in the context of the war, that has opened up new opportunities for public involvement in policymaking. But your experience is broader than Ukraine. You've also worked, I think, in contexts in which there isn't the same degree of inclusion in terms of the political process. So I'd be really interested to know if you think that, lessons that we might learn in Ukraine, for instance, can be readily applied to other parts of the region where the political institutions are not necessarily conducive to that kind of public participation. Over.
Thank you, Mark, and thank you, Simon. Yes, two very difficult questions. So first of all, to Simon's question on this kind of deliberative democratic processes in wartime. Now, I have to say that we don't have, at least I don't, and I've done some research on fragile and conflict-affected settings and health financing. We do not have examples of this, let's say, in wartime, right? I think that's a tough challenge. At the same time, I think the imperative becomes even more significant at the wartime. Well, even every war, the reasons for the war and what it implies for legitimacy of the government, that of course differs, and hence the response would be different. But for example, in case of Ukraine, and some colleagues might disagree with me, but there has been as post-Maidan, there was also a very big push for decentralization reforms, right? Which also is supposed to promote the local voice and community. But since the war, there has been some pullback for this decentralization processes in some cases. Partly this, some would say, even the biggest decentralization champions would say, okay, that's kind of justified, the country is at war. And so there are certain things that I guess, as a result of the war, you have to, pull back, let's say. But at the same time, I think Ukraine is showing that it is, they still conduct this, for example, the population surveys on like what is most important. Do you want to tackle corruption? What do you think should healthcare reforms be? So they do have those surveys. Somehow that structure is still in place. I don't know of any other context where this was still continuing to work like that. I also know, for example, that they still try to, there's a requirement that they have to put out a draft law or on a website and kind of make it publicly available while it's being discussed. And that is still being done because now, but I feel like that's a very passive kind of way of consulting people, right? And South Africa has an example of doing that, but doing it a bit more actively. I mean, I know South Africa also has issues, especially recently, with its democratic processes, but at least until sometime recently, when they were introducing sugar beverage tax, I think they often put the National Treasury of South Africa as the real example of really good reason giving by a public body. I mean, the kind of reason giving that they went through, and the document is still on their website, when introducing that tax. It's almost like answering the peer review journal, right? But in a language that is comprehensible by stakeholders. So I think, Ukraine still puts out the laws on the website. People can read them. Now, whether they have time and brain space to read and reflect them, that's a second question. But they do that. But then if they're doing it, there might also be maybe some mechanisms to have that loophole, of collecting their opinions and somehow responding to that, not just putting it things. And using those surveys that they do conduct more effectively. I think Ukraine still has very vibrant civil society, and that still could be used, And so I think I don't know how exactly to do it, but the details, as I said, were kind of messy when we were trying to set it up, some of these things. But I think Ukraine could have one of these lessons for fragile and war-affected settings on that it is possible to do it. So that's a bit on Mark's question. on how and lessons from other to other countries that Ukraine could share. I think when it comes to this kind of processes, that first of all, I think what I just noted now, I think it is still quite amazing that in the war that they have now, the country is trying to still go on with some of these processes, right? At least that they established before the war. That is something I think could be done. Could other countries also learn from? But that kind of we should not also forget that the human capital. I think the level of human capital is quite high to begin with. I think Ukraine might not be the case in all low middle income countries that are often ravaged by conflict. So that's one issue. The other issue is that I think what Ukraine is showing is that the process, the decentralization that they've started before the war played an important role in the resilience, and also I think in kind of safeguarding some of these democratic processes. And I think it's I think in the recent paper that we're looking at the resilience of primary care, we did say that the decentralization process, the empowerment of municipal local government authorities, and the financial and managerial autonomy that was there at the provider level, that was really an important factor. And I think that's also still an important factor for this procedural fairness. And I think that's not something that you see a lot in low middle income countries. And that I think is definitely something that other countries can draw on. And I would definitely say that even while certain re-centralization processes are happening, and justifiably perhaps happening, that it is important to preserve some of those post-Maidan processes as well. All on my side.
If I may, I would like to add.
Oh, sorry. Recalling the tradition of Ukrainian Democratic Society for recollecting about Maidan, and I see that there is a continuation of comments. Nataliia, yes?
Yes, I would like actually maybe to elaborate on some of the very good points Elina raised, because I think Ukrainian society is on our way, yes, to be heard by the government, and there are a lot of different tools that we are trying to implement. Specifically for health, we are supporting Ministry of Health with conducting 2 big campaigns. One is called Hrevstsova campaign, which is actually to educate patients and to expand their knowledge about what services covered by the program of medical guarantees. And in opposite to that, not in opposite, maybe in contribution to that, we have also the Ukrainian worldwide like survey, which is called like patient voice. In Ukrainian it's Голос пацієнта, when we are supporting Ministry of Health with asking different questions. For example, we know that I don't know, like acute stroke disease is very high burden here in Ukraine. Let's ask patients what are their experience about receiving these services, what are their barriers, what are kind of very different aspects of service delivery, provision, and receiving these patients. That actually, like Hrevstsova campaigns covered more than, for the whole period, more than 18 million people who are responding to our questions. And the response rate is more than 70% of all of the network that we asked. The voice of patient has very similar numbers because we are using very different tools for doing that. I would say that this is like the first steps, right? Like coming back to the start of the reform, we have like 0 these tools, and if you have like complaint or your opinion as a patient, you have like 0 chances to say this to someone in the system. So now we are trying, I think, like building all of that. And I have to correct myself maybe in my previous comment about anti-corruption strategy. We do have the overall country anti-corruption strategy, but we don't have anything specific for health. I think that's something that also could be considered in the next iteration. So thank you. I think all of the thoughts are very valuable for Ukrainian context, and we have a lot to do list, I think, here in Ukraine to improve our health system. Thank you.
Thank you very much, Nataliia. You know, I'm looking at the room and I see that nobody leaves. It's lunchtime. We are we are a bit late, but people express their interest. And before I give a floor to Mark for the final comment, I would like to ask whether there is anybody in the room who would. Yeah, I see. Who is willing to ask the final question? We can sit here until the reunion because there are lots of issues. There were lots of issues raised. There are lots of issues left to be raised, but time flies. So I will be happy to give Solomia a floor for a very, very short comment, please.
I'm very sorry to take away from your lunch break. So I just wanted to provide a comment because for us, working on health financing governance has been a key issue. And we're looking at it a little bit from a different perspective from what has been mentioned from the patient perspective, but actually from the government perspective. So one of our big projects right now is setting up the governance of the program of medical guarantees. How does the government make decisions? What is included in the program of medical guarantees? What is excluded? What are new packages? What are the tariffs, etc.? So right now, unfortunately, how the PMG is set up is on a yearly basis, the PMG is reviewed, some meetings are held, some discussion is held between Ministry of Health, Finance, and HSU about what should be included, what should not be included, etc. And there's a lot of political influence on all of these decisions. And we often see in December, just before the final decisions are made, everything turns around and everything is changed. So one of the things that we have been actually working on is to set up clear processes that by X date, that everything needs to be in place. All of the decisions need to be made about the budget, what is going to be included, what is going to be included in the most transparent way possible so that we have less political influence on some of the decisions. Because very often decisions are not made for the benefit of the patient, but made for a number of other reasons that I think you can imagine. And the other thing that we are working on with the NHSU, Ministry of Health, and Ministry of Finance is actually setting up a board around the governance of the PMG so that the Ministry of Health, Finance, NHSU, and other relevant stakeholders, such as the Cabinet of Ministers, President's Office, Parliament, that they can engage in the decision-making of how to ensure what is included, what is excluded in the most accountable, transparent way. So this is something actually that we are working on right now, that we had just a meeting last week with all of the counterparts to set up how these processes will look like. And we're working on the package of legal documents to set all of this up. So even in the context of war, there is a lot that is happening to really ensure this transparency and accountability that is so important. So I really don't think that war is an excuse for anybody to improve any of the accountability measures and to improve how financing of health services is done.
Thank you very much, Solomia, for such an informative and inspiring comment. Is there anybody here who insists on a question or comment? Yeah? Yes, please. If you insist, then okay, but please, be, if possible, very short comment.
Hello.
Because we need to follow up the standards of democracy. So please introduce yourself.
I'm Anna, a student at Kyiv Medical University, and I have a question for but yes, for you. I need some help with translate. I think maybe who can? Okay. Okay. Як нам вже відомо з досвіду різних країн, існує безліч шляхів та напрямків для досягнення належного функціонування системи охорони здоров'я і підвищення рівня довіри населення в цій сфері. А які саме, на вашу думку, найбільш вагомі кроки вашої країни ліквідували або ж сприяли мінімізації корупції у сфері охорони здоров'я? А які кроки, навпаки, викликали труднощі в практиці застосування?
Thank you. It's a very important question. If I can just translate, you just asked what were the steps of Polish government, of Polish society to stop the corruption. Yes, that's the main question. So I think that mostly it was work of the government, but it was also the democratization and giving the voice to the people and to the doctors. In fact, when we have the chambers, they can give their own voice, they can give their own opinion, they can help to resolve the problems in their own regional chambers. So thanks to that, we can cope with it on different levels, on the regional level, on the city level. And in fact, it went very well because Poland had the big problem of the corruption, but now I guess it disappeared. It mostly disappeared. As I remember from one of the speakers, we had the slide with the perception of corruption. I guess in Poland, it's still quite high, but it got lowered. So creating the chambers, creating the law, but creating the law with the voice of the doctors, that's the main step. Hope I answered it right.
Thank you very much.
Thank you very much for an excellent question and for an excellent answer. Oh, Maya, I'm sorry and I'm happy at the same time. Please.
Доброго дня, я українською. Двірська Оксана, працівник Київського медичного університету, зокрема, представляю факультет безперервного професійного медичного розвитку. Хочу подякувати за можливість участі в цій конференції. І моє питання щодо самоврядування медичних професій, щодо можливості та щодо загрози. Ми ж знаємо, що в червні цього року вперше, за 32 роки незалежності України, був в першому читанні ухвалено закон про самоврядування у сфері охорони здоров'я України. Все ж таки хотілося проговорити про ризики, на вашу думку, прийняття такого закону, оскільки без перебільшення все ж таки цей нормативно-правовий акт впливає на всю медицину в країні. І в суспільстві є полярні думки. Якщо ми говоримо про позитив, то це про визнання вільних професій і про передання їхнім представникам функцій самоврядування, що є перевагою демократії. Да? Якщо ми говоримо про негатив, то це про ризики все ж таки загнати фахівців в систему, де окремі групи все ж таки зосередять на собі і контроль за медпрофесіями, і за грошовими потоками. Дякую.
Thank you very much for an excellent question. Will you translate or shall I translate?
Please translate.
Well, maybe I will briefly translate. I will sum up the question. It dealt with self-governance of healthcare professional self-governance, and Dr. Oksana Dvirska, who represents Kyiv Medical University, the Continuous Medical Education Department, asked about risks. There are certainly advantages, but there are always some risks. So what are the risks? If you allow me, I will very briefly comment on a few risks. Well, the idea is excellent. Another thing is the implementation of the idea, the design of the idea, the legal formulation of the idea, and practical implementation of the idea. As far as the risks are concerned, I personally would think one of the risks is whether the balance between the powers, those which are vested with the government and those which are vested with professional self-regulation are achieved. So it is important to achieve a fair balance and well-grounded balance. The second thing, but this is not a risk, this is a task. As far as risks are concerned, I would say is that there is a risk of different standards applied to different chambers, risk of inconsistency. So it is important that the standards be consistent. Another thing is, this is a peculiarity of the law, that all of the medical professionals digitally will elect governing bodies. On one hand, it is good, but on the other hand, there will be no discussion in local, no discussion in regions. For example, we are at the bar, at the Ukrainian National Bar Association, have regional divisions, and it is possible first to discuss the issue regionally, and then the representatives after the discussion will be convened at the meeting and will discuss and will vote, being supplied with the opinion of their region, the region they represent. Here, this is not provided, and whether there will be transparent, open, and democratic discussion only by electronic means, this is a question. This is another risk. So actually all the initiatives should come from the bottom, but not from the top. Whether this will be from the bottom, but not from the top. Actually, this is a separate topic, and I believe that Mark, Nataliia may talk for a long about that, but this is the time which I will limit this answer. I suggest that we continue this topic at the conference on the protection of the rights of healthcare professionals, which we at the Kyiv Medical University will organize, and we are already happy to invite those who are interested to participate in this conference and to speak at this conference and continue this topic. Maybe if Mark wants to comment, I will give a floor to Mark very shortly. Would you like to comment, Mark?
Yeah, sorry, it just takes a moment to be unmuted. But should I just summarize and then give everybody the opportunity to get some lunch, Radmyla?
Yeah, it would be perfect if you answer and then summarize. And I will just say one final sentence, and we may go to the lunch. We will be a little bit undemocratic because we have no choice.
Okay, well, so just to come back on the particular issue of professional self-governance in a minute, but I guess just by way of a sort of a final set of comments. So in the afternoon, we're coming back to some big questions around what we think the critical policy relevant gaps are, what the limitations in knowledge are, and how we might try to collaborate as a research community to address them. So to build a bridge between, I guess, this session, which was incredibly rich, and I would thank all the panelists for their brilliant presentations, just building a bridge between those presentations and the discussion and what we're going to be talking about this afternoon, I might just pose a few questions building on what we've heard. So obviously Simon's presentation and program of work, really interesting and in a way challenging for us as a research community. As I mentioned, in health policy and systems research, we often formulate our questions in a very technocratic way, and we're thinking about building an evidence base that can inform and hopefully optimize sort of technical solutions to technical challenges. But Simon challenges us to think about things in a slightly richer way, a deeper way. We need to understand the political and institutional context in which these problems emerge, and in which shape our ability to recognize and respond to them. I think that's easy to say. We need to recognize these institutional constraints in our work. What I think I would like to understand and discuss a bit more this afternoon is what that really means in practice. So beyond just recognizing that in our research or in our practice, but thinking more carefully about what it really means. I guess related to that, in terms of the question of public involvement, you know, I think we have to think quite carefully about this. So, you know, learning from Ukraine's experience in terms of public involvement in health financing policy, really, really fascinating. Ukraine can learn from that. Other countries can learn from that a huge amount. But in Ukraine, we are dealing with a country with a strong civil society, a highly mobilized society. And even in the context of the war, that continues to be the case, as Elina mentioned, and Solomia has just mentioned. I think we have more to do when we seek to understand how that kind of citizen engagement can happen in countries within the region with much less inclusive political institutions, of which there are many, right? We do have autocratic states within the European region, as it's defined in global health. So it's very easy for us to say, oh, we can learn from the Ukraine experience and we can apply it here, but actually, is there a context in some other countries which would actually be conducive to that kind of approach? And if not, you know, what do we have to say as a research community and a community of practice about what can work in those kinds of societies? On corruption, I was really fascinated by Dina's presentation and Natalia's presentation. It's wonderful work, actually, just in relation to the latter, and also picking up on what Dina said. You know, we really need to do more sort of cross-country learning in this area. Also, there's a sense that within Ukraine, we might have some cross-service domain learning to do, because, Nataliia, it looks like from your presentation that the outcomes in terms of primary healthcare have been much better than they have been in specialized care. So what can we learn from PHC that might be applicable to other areas? Obviously, there are different dynamics in those different service domains, but there might be things that we can learn. And then just to encourage you and others working in this area to make sure that the work is disseminated as widely as possible, and that there is an attempt to engage in international discussions. Dina points out that Ukraine is in many ways a sort of leader in this area. And so there is much for other countries to learn. And so it would be wonderful, Nataliia, if we saw that wider dissemination of that work, and that having an impact in Ukraine and internationally. So to return to the question around self-governance, Radmyla, just at the end here, it's really fascinating to work with you on this topic. It's a bit of a reach for me. I hadn't previously done work on self-regulation or self-governance. One of the reasons I'm really interested in it is because I do think it links very well with these broader questions around the appropriate role for the state versus society versus civil society actors like professional associations, how you can ensure that you're placing power where there is capacity and where there is responsibility. Sometimes that means the state divesting itself of power and others taking on the responsibilities. At the same time, when you give professions autonomy, you know, professionals have power, professions have power. And when you give them autonomy, there also needs to be an accountability framework. There also needs to be a way in which the broader public can also exert their influence, so we can make sure that these new institutions serve the broader public interest and not narrow interests, not only the professional interest. So it's great that you're contributing to the evidence base around how we can do that. And more broadly, I'd encourage everyone to think about how we can contribute to what good practice looks like in terms of that balance between the state and other actors, including the professions, and how we can make sure that those institutions reflect the patient's interest and the broader public interest as well. So we have some excellent preliminary directions for future research, and very much looking forward to taking these on and other questions in the afternoon session.
Thank you very much, Mark, for a perfect summary of the session. I will just say one sentence in the direct sense of this word, a few sentences words in the direct sense of this word. So maybe some ideas for our future work based on this session, and some links to the session which will be then now now shared by Maya. So what can we take from this session? First, I believe this is the feeling of interdisciplinarity, of the necessity of interdisciplinarity, of the necessity to seek for a fair balance, flexibility, which was one of the strengths of Ukraine and Ukrainian healthcare system, but at the same time, we have some weak points like formal approach, for example, to the comments from the public, etc. But this can be overcome. So there are more strengths than weaknesses, and certainly such sessions will give much for looking from a bit larger perspective. I believe that starting from the first presentation and up to all the comments, we had a unique opportunity to look at many things from new perspectives, from new angles, through new lenses, and to broaden our perspective. Thank you very much for organizers, for panelists, for contributors, for everybody who answered questions and who are still here interested in what we have discussed. Thank you.